Vishalam, whoever has not raised their hands, you read the names.
Sir, almost everybody has raised. Sandeepan.
Now you quickly.
Yes, sir.
No. 11 names, sir. It takes 1 minute. You quickly read. Quickly 11 names now. One from beginning.
Okay.
If there is any issues, let them raise their hands with the video on. Please pass.
Now I'll call one by one. Just you raise the hand on your video. Kavita.
Yes, sir. Good morning, sir.
Okay. Narayan Santuka.
Yes, sir.
Swasti.
Yes, sir.
Who has logged in with 2 devices? See, any indiscipline in the Zoom platform, there is no luxury here. We will be removed.
Krishna Das. Abhijit.
Yes, sir. Yes, sir.
Sandeepan.
Yes, sir.
Gopika.
Yes, sir.
Harshini.
Yes, sir.
Oves.
Yes, sir.
Naren.
Yes, sir.
Shruti Prajnakar.
Yes, sir.
Okay, done, sir. All of them are
Fine.
there.
So then we'll start the proceedings. Good morning, dear friends. Welcome to our judges. Dr. Rawat sir is there. Dr. Bhagwan Sharma sir. Sharma ji, you are there. Sir, one second. Good morning. Sharma ji sir is there. I made both of them co-hosts. I request I will mute all of you, then unmute yourself so that it's easy for us to continue. And if there are any disturbances in between, I'll mute all, and all the participants should remember that they have to unmute and start. There could be some disturbances which we can't control from here. So I will mute quickly all, and the participant who is presenting is going to unmute himself and start. Is that fine? Okay. Now I would invite Dr. Jagdish Chinappa, our president of Indian Academy of Pediatrics Respiratory Chapter, to give the opening remarks and inaugurate the session. Dr. Jagdish Chinappa, sir.
Good morning, Dr. Subramania, Dr. Srisalam, and other members of our respiratory chapter. I can see Dr. Sharma and Dr. Rawat and all the others, Dr. Randhawa. Welcome to this wonderful session in the morning, Sunday morning, of the PGs presenting their best cases that have been chosen by the eminent faculty. I'm sure that this will be really a most exhilarating morning. Unfortunately, I have another meeting to attend, so I'm sorry, but I will not be there. I will try to join in between. I can see Dr. Gurdeep also. Welcome, Dr. Gurdeep. And wishing all of you the best. Present well. Don't be nervous, even though it's a virtual platform. The judges are your friends and they will mark you very favorably. So don't worry and present very comfortably. All the best.
Thank you, sir.
So thank you, Dr. Jagdish. Can I invite our judges today? Myself, I'm Dr. Subramania NK. For the participants, as Dr. Jagdish has rightly told, I'm the Honorary Secretary of Respiratory Chapter, and today, for logistic purposes, I will also be one of the judges because students from my college are not participating, so I will be one of the unbiased person. Secondly, we are very happy, and first of all, we want to congratulate you for coming to this level. Let's all clap for you. You are the best of the lot who have come up to this level. So we are proud that you have got some interest in respirology or pulmonology, and therefore we'd like to see you post MD career in pulmonology itself henceforth to follow. So with this warm note, as Dr. Jagdish said, don't be nervous. Case presentation is a learning. Many of us are not able to solve cases even now, in spite of years of experience. And it's learning for not only you, it's for everyone. And all of us are students in a way or the other. So we have all gone through this phase. And but I wanted to also tell you, competition is a competition. If there is no nervousness or chill, there is no meaning, isn't it? So it makes sense that if there is some kind of thrill, it's always nice, and there should be thrill. Otherwise, there is no charm in the entire proceedings. So therefore, let there be some nervousness. It's always good, because at the end of the day, all of you are winners. All of you are winners. It is only we are prioritizing the winners, isn't it? You remember, there is no diagnosis at times, and there are differential diagnoses. We have 11 differential diagnoses now. So somebody comes close to the diagnosis, so you don't worry about it. Okay. So I'm telling in your own language. But first of all, from the respiratory chapter, myself and Jagdish and all of us, first of all, we are proud of you. We are really proud of you. And all your cases will be going to history in the chapter. They will all be absorbed into our Respinext news bulletin. So don't worry. So it will get published in our respiratory chapter, whether you win or not. Maybe in the order of your winning, we will publish it in the Respinext. So all the cases are pearls for us, and we will take it forward. And let me, from the chapter, thank Dr. Sri Shailam for doing wonderful background work. So all of us should clap for him, and all the students, please clap for him. He was the one who has been given the decentralized responsibility in a federal structure to take care of all the students, and he has done the justice. Do you all agree? Yes, no? If you agree, 1 marks for all of you. Starting marks. Okay, fine. So I'm very happy. And most importantly, today we have two eminent teachers who are teacher of teachers, Dr. B.S. Sharma ji, who every year teach or enroll not less than 2 dozen of postgraduates. Can you imagine, the largest institute with largest number of inputs, and he has galaxy of students across the country and in the globe. Proudly we call him Sharma ji, and with lot of love and affection. He is the man behind many of our activities and an inspiration for us. He is the head of the department, Professor Emeritus from Jaipur. Sir, Dr. Sharma ji, welcome to you.
Good morning, sir. Good morning to all of you.
And we have the backbone of our chapter, the man behind many pedicons and future pedicons as well, and EB of the respiratory chapter. And really, and Sharma ji, you agree with me that whenever we want, we will tell Rawat sir, and next day in WhatsApp, everything is ready. You don't know how much of hard work he does. And if I can see, if I have to put in order of hard work, he will, even you are young and postgraduates, I will tell you, he stands above you. To that extent, he does the hard work even at 2 a.m. morning. So Dr. Rawat sir, he's a professor of pediatrics from Indore, the cleanest city, and most of you must be knowing his name, because he was the man behind the recent pedicon at Indore, and also the older pedicon at Indore, and many more pedicons. So, and he is also the main person behind Respicon at Indore, and he is the future for our respiratory chapter. So Dr. Rawat sir, welcome to you as one of our judges.
Thank you, sir. Thank you, sir, and welcome to all.
And I will have 1 or 2 lines from Dr. Sharma ji and Rawat sir, and then I will ask Dr. Sri Shailam to take over from there, because I will remain as judge from then onwards, and I will not interrupt in any of the sessions. So can we have 1 word from Dr. Sharma ji to our students, and 1 word from Dr. Rawat sir? Sharma ji, sir.
Thank you, Dr. Subramaniam. I'd like to extend my warm good wishes to all the participants. Friends, don't be nervous. It's a normal physiology, but we are all in a friendly environment. Do your best, and all of you are winners. Best of luck.
Good morning to all students, and do your best, and may the best person win. Best of luck to all. Okay, so let us start.
Can I request Dr. Sri Shailam sir to announce the rules of the game and give some kind of momentum to the process? Dr. Sri Shailam.
Yes, sir. Good morning, everybody. I think I have shared the screen with our respiratory ID. And today is the post-graduation case presentation competition, theme being pneumonia. We had asked the judges among the members to volunteer to become judges. And we had approximately 32 volunteers. So I think it's a big number, and we was very comfortable for the respiratory chapter. And once it was announced about the case presentation, we got 42 case presentations from across India. It was very tough for the judges to assess because all the case presentations were very excellent. Out of which, anyhow, we had chosen 11 of them, that's pan India from the different zones. So from each zone, we had case presentations. Ultimately, 11 were chosen. Yeah, just I'll put a slide of the. Yeah, these were the judges who were behind the evaluation part. None of them knew what the case, who were presenting the case, from which zone they belong, to which college they belong. So they have done wonderful job. I think they are there in the participant list. I request all the judges to identify themselves so that we can make them as co-hosts, sir. So from the north, we had Dr. Devendra Gaba, Dr. Subodh Gupta sir, Dr. Karambir Singh Gill, and Dr. Ravi Sahota. A big clap to them. From Central Zone, Dr. Vamshi Krishna Kondle, Dr. A.S. Kiriti, Dr. Arun Jain, and Dr. Sonia Bhatt. Excellent. Again, they were very prompt. From South Zone, Dr. Bhaskar Shenoy sir, Dr. Chidambaram, Dr. Gayatri Devi ma'am. From West Zone, from West Zone, we had Dr. Suhas Kulkarni, Dr. Sachin Patil. From East Zone, Dr. Ajit. So these doctors volunteered and they did the job excellently. It was very much unbiased and none of them, and it was total transparent. And even Dr. Subramaniam sir, I have not given the details just to make it a scam-free event. So even the judges are not knowing, be it Sharma sir, Rawat sir, and even I have asked the participant not to put their description in the slides. Only the code will be there. Annotations. Okay, so with these things, I think everybody through WhatsApp will communicated about the procedure, the guidelines, what they have to follow. So we'll be shortly going to the presentations, calling one by one as per the serial number. So the code will be your first slide in the presentation. So before that, I ask Subramanian sir to see any of the participants. We have the judges among the participants so that they can be made as a co-host.
Right.
So please identify yourself, sir, because the big number.
No,
We have Devendra Gaba sir is there.
No,
Can you make him?
No, sir. Shishalap sir, please understand the point. The more the number of cohorts, the problem would be every time muting, unmuting, etc.
Okay, fine then.
But the problem of the Zoom is that the judges who would agree on the point that the Zoom proceedings won't be disturbed, I will make them co-host. But I want to make everyone. Suppose you are going to leave for breakfast, clinic, this, that, etc. Please let us know now itself. So it should not be disturbing, and it's difficult for us to call you. So
Okay, fine, sir. It's
no, no, no.
10:15.
I have no issues. Let them volunteer. Gaba sir, you will be fine. I will make you co-host. Fine, fine, fine. Sir, one should be free because one should understand that it should not disturb the participants for flow and presentation. Anybody else, please identify yourself. We'll make you co-host. Karlochan sir, will you be co-host? Gayatri Devi madam, okay, no problem. See, I have no issue of
Okay.
making anybody co-host.
Okay, sir. I think we are on time. We are
No, one
not to
second.
waste
No, there
much
is no
time.
hurry. No, 1 second, 1 second. Gayatri Devi madam,
Yes,
are
sir.
you co-host now?
Yes, sir.
Okay. You are already co-host now. Tarlochan sir, I'll make you co-host. Anybody else, please volunteer. But you should be an active participant and see that you follow all the rules of the game. And see, I will tell you a last line. Irrespective of the stature of the person, if there is a disturbance in the Zoom for the students to present, we may remove you from the Zoom, but nobody should take it offensive. Will you all be okay for this? Please say yes in the chat box. Nobody should take it offensive. It could be anyone, irrespective of their post, irrespective of what they are, stature, will not worry. But the point is that if any of them will disturb the participants in the proceedings or draw the attention on the video, off the video, etc., we will remove them. You can re-log in later. Is that fine for all of you? Please identify yourself now. If there is any issues, please let me know before itself. So it should not be that I did, why this was out, why I'm out. No egos should be there. Are you all fine with this? Fine. Okay, fine. Now we'll proceed further. What I will right now do is I will mute all. Now I would request Dr. Srishalam to be the master of ceremony, call one by one number and they will start. And I would request Srishalam sir to note the timings and announce the time that started and time that ended each time. Srishalam, are you comfortable with that?
Yes, sir. Absolutely.
Or you wanted to name someone else as the timer? Devendra Gaba sir will do that job. You relax.
Yeah, I think it will be.
It is better that no. Timekeeping is a big issue.
Big issue.
So, Dr. Devendra Gaba sir, we will nominate you as a time management person. So he will each time he'll announce 10:25 in my watch, 10:35 in my watch, etc. 10 minutes is the time given, isn't it?
Yes, sir.
And you have the authority to even stop judges from asking questions if we exceed 5 minutes per candidate.
Fine, sir.
Gaba sir, you are given complete authority to stop us. How is your granddaughter? She must be fantastic. Huh? She is our respiratory icon. Okay, so nice. Okay, fine. Good morning to all of you and all the best. Doesn't matter, we take a couple of minutes, but I will request all the candidates, please do this. Correct, no? Take a deep breath. And those of you who have not taken a glass of water, now, do you have a glass of water next to you? Anybody who doesn't have a glass of water, you tell me, I'll send from here. Fine, you're relaxed. Fine, fantastic. Now, this is the time to start. Srishalam, you announce the first case and the time.
Okay, sir.
Announce the time of starting.
Okay. Let us start now. I tell the case code number 5, serial number 1. You can start. You can start screen sharing. And Dr. Gaba sir, you can unmute yourself. Gaba sir, unmute yourself. Yeah. And once they start sharing the screen, you can just start the timer.
Yeah, start. It is 10:22 right now.
Yeah. Does she have some issue? You can unmute yourself. Sir, make her co-host.
Why she went off the co-host again in between? See, I asked. Now,
She was there, I think.
Now, Kavita.
Just raise your hand. Just raise your hand. Once again. Yeah.
Are you fine now?
Yes, sir. Good morning, sir. Sir, due to network issue, I'm
Relogging again. Okay. Fine.
relogging. So please,
No issue, no issue. See, we don't worry.
Okay.
We want you to be comfortable. 1 or 2 minutes either
Yes.
other is okay, not in the presentation. Before and after the presentation, whatever you want, you can discuss. Fine. So are you comfortable now,
Okay, sir.
Kavita? Is your
Yes, sir.
presentation ready in the laptop? I will request all of you,
Yes.
again, don't mute, unmute, go out, go and come in. All this will be counted in 10 minutes. Keep your PPT open in the laptop ready.
Yes, sir.
Kavita, are you ready?
Yes, sir.
Then Gaba sir, you announce the time.
Yeah, start. It is 10:22. Kavita, start.
Good morning, everyone. I here present a case of recurrent wheezing. A case of recurrent wheezing. 10-year-old male child presented with the complaint of cough and breathing difficulty off and on from 9 years. Fever low grade from last 5 days. Cough was acute in onset, predominantly dry in nature, but occasionally expectoration was present. Cough was more in morning. There were changes in the severity of cough with change of season. Uh, Cough was not associated with postnasal drip, hacking, irritation in throat, and no evidence of blood in sputum. Breathing difficulty off and on from last 9 years. Increase in breathing difficulty for last 5 days. Breathing difficulty was episodic, varies with seasons. It was of grade 3 MMRC dyspnea scale at the time of presentation. No evidence of paroxysmal nocturnal dyspnea was present. Child had fever off and on, which was low grade, intermittent, not associated with chills and rigor and night sweats, relieved with medication, and most of the episodes were afebrile. Child has no history of weight loss, palpitation, chest pain, bluish discoloration, allergic rhinitis or atopic dermatitis, no coughing or choking during feeding, and no history of food and drug allergy. Patient consulted multiple practitioners during last 9 years of illness. He was put on ATT on the basis of chest X-ray finding by local practitioner. No, taken ATT at the 8 month of age and 8 year of age. No microbiological diagnosis was documented. Patient also treated as a bronchial asthma and was put on salbutamol and budesonide inhaler therapy at the age of 3 years. He was treated at various places without any significant improvement. Immunization complete. Child achieved all developmental milestones on time. Dietary history was appropriate and height and weight at a 50th centile. Belongs to lower middle class. No relevant family history was present. On general physical examination, no significant abnormality was found. Vitals were normal. Now in a systemic examination, respiratory system. Upper respiratory tract was normal. No abnormality was found. On inspection, supraesternal, intercostal, and subcostal retraction were present. Palpation, chest movement equal on both sides. Percussion reveals impaired resonance at right mid zone and lower zone posteriorly. Auscultatory findings were revealed breath sound decrease on right side, bronchial breath sound in right, middle, and lower zone posteriorly, bilateral bronchi present all over. Other systemic examination, no abnormality was were found. Now, on the basis of history and examination, differential diagnosis for uncontrolled bronchial asthma with pneumonia right side, tuberculosis, cystic fibrosis, some other chronic lung disease were made. We investigate complete blood picture. RFT and LFT revealed no abnormality. Total eosinophil count was 590 cells per microliter. Total IgE was 1531 kilo unit per liter. Pharia top was 7.31 kilo unit allergen specific IgE per liter, as IgE and Pharia top were elevated. Possibility of allergic condition were considered. ESR 34, CRP 9.3 mg per liter. Montus test was negative and sputum for gram staining show gram positive foci in pairs and culture and sensitivity show sterile. CB net was negative and pulmonary function test
5 minutes over.
moderate obstructive pattern with positive reversibility. Chest X-ray was normal. HRCT of chest show foci of consolidation with the atelectasis in medial aspect of bilateral lower lobe, and the multiple small nodules and linear branching lesion in both lungs, predominantly involving right lung, few enlarged lymph nodes in mediastinum, and the central distributed nodules along with the minimal bronchiectasis was found. Further investigation bronchoscopy was done. Thick mucus plug was extracted and sent for culture sensitivity CBNet KOH mount. Post bronchoscopy, there was improvement in system. ABPA panel, mini panel was sent and is show elevated Aspergillus fumigatus specific IgE, which was 0.39, and the BAL for bronchoalveolar lavage for CBNet was negative. Now we discuss the differential diagnosis one by one. In a long-standing cough, seasonal or diurnal variation, breathing difficulty, intermittent low-grade fever, pulmonary function test findings favor the bronchial asthma, but the radiological changes and the very high serum IgE level, which was a 1590, favor the other associated something else was there. Long-standing fever and chronic cough favor the tuberculosis, but child was active, no lethargy, gaining weight normally, no history of close contact, Montus negative, and a CB net for both BAL and sputum was negative. So we rule out the tuberculosis. Cough off and on, intermittent acute respiratory infection, shortness of breath, and a bronchiectasis favor the cystic fibrosis. But in our child, no growth stunting was present, no clubbing, no sudden significant clinical deterioration was present, no nasal polyp, and no GI symptoms or a pancreatitis. So we rule out the cystic fibrosis. Cough, dyspnea, wheeze, and a serum IgE, which was a 1590, favor the tropical pulmonary eosinophilia. But in our child, no malaise, no anorexia, no history of weight loss, and no marked peripheral blood eosinophilia, and no hepatosplenomegaly and a generalized lymphadenopathy, which rule out the tropical pulmonary eosinophilia. In our case, uncontrolled asthma, total serum IgE, which was 1590, specific IgE for Aspergillus fumigatus was elevated, HRCT chest revealed bronchiectasis and lung collapse, thick mucus plug in the bronchoscopy favor the bronchial asthma with the allergic bronchopulmonary aspergillosis. But against is the skin prick test for Aspergillus fumigatus, which come negative. In our case, all the diagnostic criteria fulfilled, which by the ISHAM. So on the basis of history,
2 minutes
examination,
left.
and
2 minutes left.
investigation, bronchial asthma with allergic bronchopulmonary aspergillosis stage 1. Patient was discharged on the tablet prednisolone along with the levoflox, Foracat, and Levolin. Patient came for follow-up after 15 days, clinically improved, and on further 2 follow-up, child was asymptomatic, gain weight, and the patient is presently on tele-follow-up due to COVID pandemic, keeping fine and on Foracat inhaler only. Take-home message. Early diagnosis of ABPA is essential for preventing irreversible lung disease. Efforts should be made about knowledge and awareness of in the general population as well as in the medical practitioner to prevent misuse of anti-tubercle drugs. ABPA is a well-recognized entity in adults and now increased recognized in children and need to to have a high index of suspicious at an early stage to prevent fibrosis and prevent irreversible lung disease. In 2 articles, we show the should be investigate the patient who present with the uncontrolled bronchial asthma and high peripheral blood eosinophilia should be investigated for ABPA. Effort need to be intensified to improve the awareness along general physicians. ABPA is a very rare disease in pediatric population. Thank you.
Thank you. 9 minutes over.
So over to you,
Over
sir.
to Sarasalam.
So Sharma ji, sir.
Any history of foreign body or choking?
No, sir.
Any associated comorbidities?
No, sir.
Any snoring, mouth breathing?
Sorry, sir.
Any mouth breathing, snoring?
No, sir, no history of snoring or mouth breathing, but
Any response to the bronchodilators or the anti-asthma medication?
sir, a patient responds to bronchodilators in a shorter time. Then after that, sometimes not completely relieved with bronchodilators, but some extent he relieved with bronchodilators. And after the sometimes we persistent cough and breathing difficulty and repeated hospitalization, history of repeated hospitalization were present.
You said the child had recurrent episodes of cough and breathing difficulty. You had
Yes,
a
sir.
localization in the right lung.
Yes,
How
sir.
you called it uncontrolled asthma? The history is
Sir,
only for
because
5 days.
no, sir. Sir, cough and breathing difficulty since 9 years, and which patient
9
on the
years.
bronchodilator since the at the age of 3 years.
Since
I'm
when the
mentioned that
asthma is
patient was on.
uncontrolled? Initially, you said the child showed response, means he was well controlled.
Yes,
This time,
yes.
the episode is only lasting for 5 days. So when it
No,
was
sir.
uncontrolled,
Patient was came. Sir,
when you believe
patient on
uncontrolled,
bronchodilators at. Sir, patient on now at the in our case the since 5 days patient has a history of breathing difficulty which was an increase, but this repeated hospitalization after the patient on budesonide and salbutamol inhaler, but not controlled.
no, but you only
Um,
mentioned the child had recurrent episodes. That was fine for last 9 years. The only problem now is 5 days.
Sir, in our OPD patient was came with the very severe difficulty
It is
and
not
not
your
controlled
OPD.
patient.
The present history is only for 5 days. It's not
No,
your
sir, no,
OPD or somebody else OPD.
no. See, sir, in a case, our in when patient came in our OPD, five
It was point
continue.
against a forgotten foreign body.
Sir, patient have a no difficult breathing difficulty was present, but no choking or
You may not get that history. Why it
yes,
was
sir.
not kept in the DD? Why not glottic stenosis? Subglottic stenosis?
Sir, if the patient had a history of foreign body or glottis, the long foreign body with patient had a history of 9 years, which was not.
Yeah, he responds often on to antibiotics. Now the child had bronchiectasis, fibrosis, everything. Okay, Dr. Rawat, please.
Okay, Kavita, I think I will come to your rescue, just like internal examiners would do. Sharmaji sir, you and Rawat sir can take tough stand, but for me, I will make a soft stand. Kavita, do you think a foreign body would be localized or bilateral disease, if at all, unless it is migratory?
Sir,
It would be
sorry, sir.
usually. What is your take on that?
Sir, in our case, the mucus plug was present in a, which was we extract in a by bronchoscopy.
No, your case, is it a localized disease or a diffuse disease?
Sir, it is a diffuse, not a localized disease, sir. It is a diffuse.
One. Okay. The second thing is it a progressive disease or a non-progressive disease?
Sir, it is a some extent if the patient was not taking proper treatment, it is a progressive if the patient was progressive disease if not taken treatment properly.
Is the current element a complication of a pre-existing disease or is a disease by itself?
Sir, it is a complication. It is the hypersensitivity reaction of the body on the immune response.
Fine. I would have two more questions to you. Tell
Yes,
me
sir.
what is the treatment for ABPA?
Sir, ABPA, the first main treatment was the corticosteroids with the adjuvant therapy with the antifungal therapy or omalizumab, and other therapy was the omalizumab was given.
Okay. No, I don't want to get into too much of that because it may be at PG level too many questions for you. What is eosinophilic pneumonia?
Sir, in the eosinophilic pulmonary pneumonia, patient can patient has a complaint of cough, fever and everything, but in the acute, and these are the two type, acute and chronic pulmonary eosinophilia. In the acute, patient complain of high eosinophilic counts and the peripheral high eosinophilic counts, and also the history of hypoxia, and the other organs are also involved due to the eosinophilic count. And
Right.
this has the three stages. In the first was the asthma and the rhinitis, and the second was with the tissue eosinophilia, and third was the fibrosis.
Time up, sir.
Rawat sir, you can continue, sir.
Yes, Kavita, well done. I'll ask only two questions. First, in
Yes,
your
sir.
history, you told that there is no history of postnasal drip. So how do you ask the history for postnasal drip? You
Sir,
told in your history that there is no history of postnasal drip. So how would you ask history of postnasal drip?
Sir, I asked in a postnasal drip history.
What type
Sir,
of history you get in postnasal drip?
sir, ask to patient, and when the after the
Relax, relax. हाँ, आराम से बोलो. I'm your internal examiner. Don't worry.
जी sir.
What is the question you put to the patient to know about postnasal drip? When is the cough more?
Sir, you are also becoming internal examiner. That's the weakness of teachers. Okay.
Sir,
No, Kavita, you relax. Don't worry. You have done well. You answer a couple of questions. What happens when they
sir,
lie down and
sir,
how many
history of
minutes?
the throat, sir, frequently अपन sir throat का we ask the patient to clear the throat frequently or not.
You mean to
Or
say throat clearing cough?
yes sir, do you मतलब clear the throat every after some times?
Is that your answer? Are you sure? Okay. What happens when he lies down 10-15 minutes later?
What sir? Sorry sir.
Suppose a child
From
with postnasal drip lies down. What happens after 15-20 minutes?
sir,
Okay. What is the source for the postnasal drip? From where the drip comes? There has to be some origin for the river. You understood the question or difficult? It is dripping.
sir,
From-
sir, it is sir sinusitis, sir, जो sinus, sir.
Okay. But tell your people around in the background not to give you hints, sir. Okay.
No, sir. So no.
Okay. Doesn't matter. You are all learning, so we don't mind. But
Yes, sir.
no, they are not giving. You are distracted. So I thought that somebody is still teaching you from.
No, sir.
No, it's
Sir,
okay. Don't
actually,
worry. Even if you don't
sir,
know, it's all right, ma. There is a lot of long way for you to know things. So are we done with 5 minutes?
We have exceeded by 2 minutes.
Huh?
We have exceeded by 2 minutes.
We have exceeded?
Yes, sir. We can
Okay,
stop.
fine. So sorry for the first one. Next time onwards, Gaba sir, please remind us.
Yeah, sure.
So it's totally 15 minutes.
Something like 1.5 minutes each for each judge. That would make
Huh.
it.
Yes, sir.
And Gaba sir, you tell at the end of 8, I would request you kindly, at 8 minutes you tell once. And
Okay.
so that last 2 minutes they will wind up.
Okay, sure.
Otherwise, when you tell 5 minutes, they may get a little.
Right.
Okay. Doesn't
So I request Dr. Sharma
anyway,
sir, Dr. Mahan sir.
first of all, Kavita, congratulations. Opening batsman, it's always tough.
Yeah.
So you always have that soft corner from us. It's difficult to open an innings always because the others will learn from what you have presented. But it is difficult for you. Can you stop sharing the screen?
Yes, sir.
Sir, till the next speaker, next participant comes, I request Dr. Rawat sir, Dr. Sharma sir, and Dr. Subramanian sir to share the marks to me personally. I'm having the scorecard. So this was code 5, case code 5, participant number 1.
Now what we will do, we will give you the results, sir, Srishalam.
हाँ सर, next presenter आने से पहले आप मेरे को भेज दीजिएगा सर. So should I call the next participant?
No, Srishalam, I will tell you what. No, it is not like that. All three of us will take 5 minutes of break, and then we'll share amongst each other and do a total.
Yes,
We
yes.
will not share
Fine,
individual.
sir. Fine.
Yeah.
Fine. Now, next serial number 2, case code 14. Yeah.
Narayan, it is 10:42. You have 10 minutes to go, right? Start. You are muted. Unmute yourself. Unmute yourself, Narayan.
Just I'll check easy made co-host.
No, why, Pa? Once we made the co-host, again, I think you are logged in, logged out. I think students are logging out and logging in. Now you are fine?
Hello, sir. Am I audible?
Yeah, yes.
Yes, sir. Sir, I was not the co-host from the beginning itself, sir.
Now, why
I would
you
like to
did
share
not
my
tell
screen.
beforehand? You should, no, any other, 1 second. Any other students who are not co-host, please let us know now itself. Yeah.
Devendra sir, you can ask him to start the time.
Yeah, Narayan, start now. Right now, 10:43.
Yes, sir.
Start right now.
Thank you so much, sir. A very good morning to the respected judges and the participants in this virtual platform. I'll be presenting a rare case which presented as pneumonia, and we ultimately led to a very rare finding. So starting, my patient, who is a 1.5-year-old male child from Bhadrak, Odisha, the informant being mother who was reliable, presented to the OPD with the complaints of fever for 7 days, cough and cold for 7 days, and difficulty in breathing for 3 days. The patient, a first-order male child born out of non-consanguineous marriage, was apparently oiled 7 days back. To start with, he developed fever, which was high-grade, intermittent, not associated with chills and rigor, and responding to oral antipyretics. The fever was associated with cough and cold, which was insidious in onset, gradually progressive, not responding to oral medications, gradually leading to difficulty in breathing. There was no history of lethargy, poor feeding, fever with rash, ear discharge, or bluish discoloration of the body. No history of any foreign body ingestion to the best of mother's knowledge. Following this, the child was admitted in the district headquarters and subsequently referred to our institution for further management. The child in the past was admitted with similar complaints around 14 months back, was managed conservatively and discharged as a case of dextrocardia with patent foramen ovale with pneumonia. There was no history of recent contact with an active or an open case of tuberculosis. There was no history of similar complaints in the family in the recent past, no history of asthma or allergic disorders in the family. Coming to the antenatal history, the mother is a 21-year-old, married 2 years back, was a booked case. She was attending regular ANCs, 2 current folic acid tablets, 2 doses of TT, and the entire pregnancy was uneventful. The baby was a first-order term male child born by normal vaginal delivery with a birth weight of 2.6 kgs, cried immediately after birth. The immediate postnatal period was uneventful, and the baby was discharged 48 hours after birth. The baby takes an average mixed Indian diet, eats from the family pot, and he also consumes mother's milk. The average calorie intake is around 520 kilocalories against a daily requirement of at least 640 calories, leaving a deficit of around 19%. And the average protein intake was around 7 grams instead of at least 9.5 grams, leaving a deficit of around 27%. The family used to stay in a kachcha house with 2 rooms, which with one being used as a kitchen and one to sleep. They were all sleeping. There were 3 members and all were sleeping in the same room. On the floor, consumed water from the community tube well around 200 meters from their house. There was no sanitary latrine and they practiced open defecation. The father is a daily laborer, studied up to 6th standard, gets around 6 to 7,000 per month as monthly income, and he's the only earning member of the family. Mother has studied up to the 1st standard as a housewife. They belong to the upper lower socioeconomic class according to the modified Kupusama scale. The child achieved all the developmental milestones as per age and has received all the scheduled vaccinations in the national immunization schedule. So with a background of fever, cough and cold, difficulty in breathing in a child with a similar past history 14 months back, and a baby with a deficient nutrition and with a poor socioeconomic status, let us move on to the examination. The baby was irritable while being examined and prefers to be in the mother's lap, not interested in the surroundings. The patient has mild pallor. There is no icterus, cyanosis, clubbing, or generalized lymphadenopathy or edema. The hair was normal but lusterless. Anterior fontanelle closed. Sutures are normal. There's no conjunctival gerosis or bit out spots, no dysmorphic facial features, no cheilitis or angulostomatitis or facial puffiness. Mucosa appears moist. Tears are present. Ears were normal without any signs of discharge. The oral cavity appears normal. The skin is dry and lusterless. There was no skin peeling or wrinkling noticed. Chest and abdomen appeared normal. Spine and genitalia were normal. Bilateral legs were normal. The temperature measured upon admission in the right axilla was 100.8 degrees Fahrenheit. The pulse rate was 110 per minute, was good volume, normal in character, no radiofemoral, radioradial delay, and all the peripheral pulses were well filled. The patient had a respiratory rate of 46 per minute, was regular, abdominothoracic type. The blood pressure was 88 by 50 millimeters of mercury in the right upper arm supine position, and it fell in the bracket of 50th to the 90th percentile according to the age and height of the baby. The baby maintained a saturation of 95% and more in all the 4 limbs at room air. Coming to the anthropometric measurements, the baby was weighing 8 kg against an expected of 11 kgs and had a length of 77 centimeters against an expected of 81 centimeters. The weight for height falling into the bracket of moderate acute malnutrition with mid upper arm circumference being 11.7 centimeters. Coming to the systemic examination, on inspection, the chest was normal in shape, bilaterally symmetrical with no bulging, depression, scar marks, or discharging sinus. The respiratory rate was 46 per minute, abdominothoracic type, with the chest movements appearing decreased on the right side, with visible intercostal retractions in the inframammary and infraaxillary areas. Nasal flaring was also present. On palpation, trachea was felt to be slightly deviated to the right side. Chest expansion during inspiration was found to be decreased in the right side, more so in the apical region, and no palpable sounds. On percussion, the notes were fairly resonant across the left lung fields. Impaired resonance was felt in the right inframammary, infraaxillary, and right subscapular and interscapular areas. On auscultation, bilateral vesicular breath sounds were heard. Crepitations were heard in the right mammary, inframammary, axillary, and infraaxillary areas. Bronchial breath sounds were heard over the right subscapular and interscapular areas. I'm sorry. Right, infrascapular and interscapular areas. Coming to the cardiovascular system, the precordium appeared normal, no visible pulsations. Apex beat was felt on the right fifth intercostal space, 2 centimeter from the right sternal border, from the left sternal border. S1 and S2 were heard with no murmurs. Abdomen was normal in shape, flanks were empty, no visible or dilated veins. All quadrants move equally with respiration, soft, non-tender. There was no organomegaly. Genitalia and anal openings were normal. The child was conscious, oriented to time, place, and person, recognizes parents. No motor, sensory, or cranial deficits were found. So now we have a baby of 18 months with complaints of cough and cold, fever, and difficulty in breathing over the last 1 week, admitted to a district headquarters and subsequently referred to a tertiary care hospital for further treatment with a similar past history with a poor socioeconomic status and deficient nutrition. Upon examination was tachypnic, having tachycardia with decreased chest movements on the right side, crepitations, and bronchial breath sounds.
2 minutes left, Narayan, 2 minutes left.
Yes, sir. Yes, sir. Let us move on to the investigations. The child, on the initial baseline investigations, had the counts of 16,900 with predominantly neutrophils and other parameters being normal with a hemoglobin of 8.5. 5 days later, the CBC was repeated and the counts were more or less similar. And prior to discharge, another repeat was done when the counts were coming to the normal range. The baseline serum parameters were done, which was again in the normal range. And after an antibiotic course, RFT was repeated, which was again normal. Coming to the chest X-ray, this We were very basic with the investigations with just CBC's and serum parameters and an X-ray. And this is the X-ray which initially created some kind of a doubt. The heart shadow is seen on the right side of the chest with some haziness in the right middle and upper lobe. And there is some increased intensity linear marking, which is clearly not visible in the left side of the picture. So I have marked it around in the right side of the picture. Now, I just wanted to clarify, this X-ray is an X-ray which was in the first admission 14 months back. I was just like to say that the X-ray looks so similar. This X-ray was the X-ray when the baby was about 5 to 6 months old, and this is around 1.5-year-old child. So this led us to investigate further, and we went for a CT scan. CT scan showed us this picture. There was an abnormal drainage of the left lower pulmonary vein into the inferior vena cava, which ultimately drained into the right atrium. I just had a very small video. I would like to show this entire. This is the video of the entire CT scan, but we can just see that the drainage and the inferior vena cava ultimately draining into the right atrium, creating this abnormal mark in the X-ray as well. This actually is called as the scimitar syndrome. We treated this case as a case of pneumonia, and ultimately the diagnosis went as a case of scimitar syndrome, which is an anomalous drainage of right lower lobe pulmonary vein to the inferior vena cava with right upper lobe segmental collapse with dextroposition of the heart with right middle and lower lobe pneumonia. Thank you so much.
Yeah, you have done it on time.
Yeah, it is on
over
time.
to
Yeah.
Subramanian sir and the judges. Over to you, sir.
Before Parmod, let us
Narayan.
question on basics. You said there is no history of chills and rigor. How a 1.5-year-old child can complain of chills? How you made this statement?
Sir, I was asking the parents, like, if.
Please be loud.
Sir, I was asking to the parents that.
What is the meaning by chills and rigor?
So like shaky movements, if there is any shaky movements along with high degree of fever, sir.
So that is chills or rigor?
So that is rigor, sir.
What is chills?
I'm sorry, sir.
Okay, leave that. So the child with this kind of picture has asymptomatic period of almost 1.5 years.
Yes, sir.
And he presented at the age of 1.5 years with just 4 or 5 days of cough,
yes, sir.
and pneumonia.
Yes, sir.
But your X-rays were not very indicative of something which you showed in the last. X-ray quality was also not good, so that you can pick it up in the X-ray. Except the dextrocardia, I think there was nothing much.
So dextrocardia was visible. More so, the X-ray was very similar to the X-ray which we had in the when the baby was admitted around 14 months back. And this is only because as the patient was not improving over a period of 5 to 7 days, so that is why we actually went up for a CT scan. And
basically non-responding pneumonia.
Yes, sir.
But you showed nothing in the X-ray about pneumonia. You said only the venography.
So there was some haziness which was not apparently as clear because of the cardiac shadow probably in the right middle and upper lobe, sir.
CT scan should show that. That is the advantage of CT over chest. The retrocardiac shadows can be better visualized.
Yes, sir.
Okay. Dr. Rawat, please.
Okay, Narayan, well presented. Now I'll ask 3 questions. First of all, when you examine a child with any respiratory problem, in inspection you have not mentioned any audible sound, because the child who is coming to you with respiratory distress sounds like audible wheeze or grunt. They are an important indicator of.
So there was no audible sound, sir. Yes.
Regarding any audible sounds.
Yes, sir. I'm mistaken, sir. There was no audible sounds when the baby presented to the OPD, sir.
Okay. Then next, you told that the trachea is deviated on the right side. So is it a normal finding or it is an abnormal finding? Because normally, if you see trachea, it is slightly deviated to the right side. So what you mean is, normal or abnormal?
So it could be a normal finding as well, but ultimately when we had a diagnosis of a right upper lobe segmental collapse, we could attribute this finding to the deviation of trachea as well, sir.
No, so in a child who is absolutely normal without any finding, where trachea will lie?
So trachea should be lying central, sir.
Centrally. Are you sure? In a normal child without any problem, the trachea will be central or it will be slightly towards the
So
right side.
slightly deviated towards right, sir.
So normally trachea is on the slightly on the right side.
Yes, sir.
You are mentioning that it is very significantly deviated, then it indicates a pathology. But just telling that trachea on the right side, it doesn't tell me anything, because normally trachea is slightly on the right
side. Yes.
Then third, you told that there is no organomegaly on examination of abdomen. So
Yes,
in
sir.
a normal child, can you palpate the liver and spleen? In a child who is absolutely normal. A child who is 2 years, can you palpate the liver? Or a child, suppose in a child 2 years, you cannot palpate the liver. So it is normal or abnormal?
So it is normal, sir.
No, like in a child who is absolutely normal, at least 1 centimeter liver.
1 centimeter liver can be palpable.
So
Yes,
if
sir.
it is not palpable, then probably it is indicating that there is some chronic liver disease, probably it is cirrhotic, because you are telling that there is no organomegaly. Whereas in a normal child who is having no pathology, liver should be at least 1 centimeter below the right costal margin. You are telling it is not palpable. That means that it's a diseased liver or what?
Sir, to comment about organomegaly, liver being palpable below the subcostal margin is only not the definitive criteria. We go for the liver span, sir. If it falls within the age bracket, we say that liver is not enlarged.
So did you do it? Because
yes,
you
sir.
are there is no organomegaly. So
yes, sir. Liver span was measured, sir. Liver span was measured. It was as with the age, sir, about 5 to 6 centimeters. In that age group, it should be within 5 to 7 centimeters, sir. And we had that. That is why, sir, I did not mention that.
Okay.
And even
and then the last question: why did you go for a CT scan? Because your finding, clinical finding, they were of a right-sided pneumonia. You had all signs of decreased air entry, cleft on the right side. So
yes,
what
sir.
was the initial indication for CT scan? Because you would have given a child a trial of an antibiotic therapy and then watch for say 5 to 7 days. So what was
yes, sir. The CT scan. I'm sorry, sir. The CT scan was done only after 7 days of admission, when the baby was not responding, was keeping on being tachypneic. The chest signs were still persisting, and we had such a peculiar X-ray picture, and that is why we went for a CT scan. Sir.
And would you call this case as a child with recurrent pneumonia? Because he had one episode passed and again second two. Would you classify as a child with recurrent pneumonia?
No, sir. This is difference is, sir, 14 months, and the pathology somewhat probably are different. It could not be even related to the heart disease.
Okay.
The child is having malnutrition. He is living in a lower socioeconomic status, overcrowded family. The pathologies, the causes can be different and variable, sir, and over a period of 14 months. So I would not call it as a case of recurrent pneumonia.
Okay.
Okay.
Yeah, we have to wrap up. Time is over. Time is over.
One or two questions from me.
Yeah.
In a scimitar syndrome, tell me what is the abnormality in the lung? See, I understand the vessel. What is the abnormality in the lung?
Sir, there is an abnormal drainage. The pulmonary vein drains into the inferior
vena. Leave the pulmonary vein. What about the lungs?
Lungs, sir, there is mostly a collapse in the lungs, sir, and it is again scimitar syndrome. It's a rare entity, sir. Average incidence is about 1 in a million, and of them, 2/3 of the cases are associated with a lower lobe collapse.
Okay.
And even rare is a middle or upper lobe collapse, as we see in this case, sir.
Okay.
And less than 30% of the scimitar syndromes have this kind of presentings. So we might have an incidence of say 1 in 3 million or 1 in 4 million, where in a scimitar, where a case of scimitar syndrome with an upper or middle lobe collapse.
No, that is the presentation. What about the abnormality in the lung? Actually, I'll tell you the answer because you have that's a rare for the benefit of others. There will be associated lung hypoplasia.
I'm sorry. Yes, sir.
Yeah, that is what was the answer I was expecting from you. And that could make the child symptomatic persistently till it makes you to take the CT scan. It is not just obstruction and collapse, isn't it? So
Yes, yes.
there is a hypoplastic lung, and therefore, it is oxygen dependent, or I don't know the case. So I'm guessing from here, probably the child required prolonged care support from you.
Sir, the child was admitted. I just like to take 1 minute, sir. The child was admitted for a period of about 15 to 20 days only. The pneumonia resolved over a period of 14 to 16 days, and we
Okay.
kept the child for further 4 days for academic purposes.
Okay.
Even the articles which we have on scimitar, they say that the child may not be even symptomatic or mildly symptomatic or asymptomatic, and sometimes the child may be even severely symptomatic, requiring persistent treatment. So we have an entire spectrum.
Now, what is the treatment that you offer to this child?
This child who is mildly symptomatic or rarely symptomatic coming to the hospital and scimitar, probably in this case we would have diagnosed scimitar as a chance, where the pneumonia could be of any other.
Great. Now we have made the diagnosis. What next?
Sir, next is a CT-based consultation and only surgical treatment, sir.
What surgery?
Sir, probably if required, resection of that hypoplastic lung segment, sir.
You want to
and correction of the vein and the correction of the drainage, sir, of the venous drainage. I am sorry, sir, I do not know the name of the surgery.
No, doesn't matter. Doesn't matter. Yeah. Fine. Sharma ji, sir, wanted to ask some questions.
Last comment, sir. For the benefit of others, what is scimitar?
The scimitar is actually like the name comes from a like ancient sword, sir, which has a curve which I showed in the X-ray. So this the vessel was similar to the curve of this sword. That is why the name scimitar.
Thank you.
Thank you so much. Well done. Thank
you. Excellent, sir. We'll go for the next case. Case code.
No, I would request Srishalam, the participants to stop sharing as soon as it is over.
Yes, okay, fine.
Narayan, please stop sharing.
You can just...
Sir, just a minute, sir. I'm pretty new. I just don't use this platform. I'm finding it difficult, sir.
No, doesn't matter.
No.
If you find difficult, exit and log in. But you will miss the whole thing because there is full 100 people. Now you stop sharing screen.
Stop share.
That screen actually is not coming.
You close it, then that screen share green color one will be there.
Red color. Red color.
Yes, sir. I get it. Yes, I get it. Yes, sir.
You mute yourself now. I'll mute all and then unmute separately. That's better, isn't it? Once.
Yes, sir. Next, we'll take up the case number. Case code 17. Serial number 3.
Yes, sir.
Gaba sir, over to you. Time up.
Yeah, Swasti, you start now. It is 11:05. You share your screen and start.
Is the screen visible, sir?
Yeah, it is available.
Yeah. Hari Om, and a very good morning, revered jury and esteemed guests. This is a case of a 12-year-old male child from Western Odisha, born out of non-consanguineous marriage to an upper-lower class family, informant being patient's mother, who presented to our hospital with a complaint of swelling and pain of the right arm around the shoulder joint for around 8 days, high-grade intermittent fever spikes for 6 days associated with a swelling and pain over the left buttock for 6 days. Patient had shortness of breath 3 days prior to hospitalization. He had a history of pyoderma over the right leg 15 days back, which was treated only with some topical medications and home remediations. There was no history of any similar illness in the past, no history of recurrent cough, cold, or upper respiratory tract infection. There was no history of contact with tuberculosis cases, nor contact with any COVID positive cases. Birth history, developmental, immunization, nutritional, and socioeconomic history in this case were not suggestive. At the time of admission, we found the patient was sick-looking, thin-built, conscious, well-oriented to time, place, and person with normal anthropometric measurements. On examination, we found the patient to be febrile, with a respiratory rate of 54 per minute with 140 per minute pulse rate, which was regular in rhythm but bounding type, with a wide pulse pressure and the saturation being 93% in room air, which improved with supplemental oxygen. On head-to-toe examination, we found that the patient had nasal flaring with pursed lips and decreased movement on the right side of chest. There was cellulitis over the right arm with a 7 into 6 centimeter size abscess over the left buttock with pyoderma below right knee joint without any associated joint swelling, and patient was anemic. Respiratory system examination proper revealed that he had flaring of alenezy with a centrally placed trachea with decreased expansion of the chest on the right side. In the right infraclavicular and axillary area, we found the vocal frequencies to be increased with dull note on percussion, bronchial breath sound present along with coarse crepitations. There were diminished air entry in the right infraaxillary area with few crepitations present in the left infraaxillary area as well. Cardiovascular, GI, and CNS examination were within normal limits. With this, we made a provisional diagnosis of a case of lower respiratory tract infection with right upper lobe consolidation and left side bronchopneumonia with right arm cellulitis and left gluteal abscess, etiology being infectious, most likely bacterial in origin, presenting in shock. The investigations at time of presentation we sent revealed neutrophilic leukocytosis with microcytic hypochromic anemia with reactive thrombocytosis. There were raised acute phase reactants. COVID-19 RT-PCR was negative and the biochemical parameters were within normal limits. The X-ray on day 1 showed right upper lobe consolidation. ABG was suggestive of respiratory alkalosis. Right arm ultrasound suggested only subcutaneous edema that suggested cellulitis. Ultrasound left gluteal region was suggestive of an abscess, and ultrasound thorax showed bilateral pleural effusion with multiple septations and thickened pleura. Patient was immediately shifted to PICU, was started on oxygen inhalation with normal saline bolus and vasopressors. We sent blood for culture sensitivity study and started the patient on broad spectrum IV antibiotics along with staphylococcal coverage. Incision and drainage of the gluteal abscess was done and we obtained 30 ml pus which was sent for culture sensitivity study. Shock gradually improved and we omitted the vasopressors and packed RBC was transfused. Pleurocentesis was done. We obtained 20 ml of serosanguinous fluid, which was again sent for culture sensitivity and cytological and biochemical evaluation, which was exudative as per Light's criteria. Even after 48 hours, we found the patient's condition to be worsening. Swelling progressed. Patient had several spikes of high-grade fever. Vitals worsened. Repeat ultrasound again showed bilateral pleural effusion with multiple septations and counts had increased. This is a short video of the patient showing respiratory distress with diminished chest expansion. Patient was connected to non-invasive ventilation with such vitals. Antibiotics were upgraded. Injection clindamycin was added. With BiPAP, patient was more comfortable, however, still had some respiratory distress. We gave intercostal drainage tube and injected injection streptokinase for fibrinolysis. After 72 hours, we removed the chest tube and the tip was sent for culture and sensitivity study. By day 7, we found no significant improvement in the patient's condition. High-grade fever was persisting, and on chest, we found bilateral diffuse crepitations. By then, we received the blood, pus, and pleural fluid culture, all of them being negative. Tubercular workup was negative. We did certain tests to rule out acquired immunodeficiency states like sickling, which was negative. Triple H marker was negative. And since patient has persistent high-grade fever, we sent a repeat blood culture. The chest X-ray by that time showed progression of the original lesion with new onset, patchy and nodular opacities in the left lung field. Because of this, we planned for an HRCT thorax, which was suggestive of right upper lobe and middle lobe consolidation, along with multiple nodular lesions with central cavitations in bilateral lung field with feeding vessel sign. This was suggestive of necrotizing pneumonia. After HRCT reports, we plan to send a tracheal aspirate to rule out fungal etiology. 2D echocardiography was done, which was normal. Fever, however, persisted. Swelling and pain in the right arm persisted, but even then, ultrasound showed no evidence of septic arthritis. By day 14, we received the chest tube tip culture report, which isolated Staphylococcus aureus, which was sensitive to linezolid, gentamicin, teicoplanin, and partly sensitive to clindamycin, but resistant to vancomycin. Tracheal aspirate was again negative for fungal balls or fungal IP. Repeat blood culture report was received, which was negative. We upgraded the antibiotic as per sensitivity pattern, and injection linezolid was added instead of injection vancomycin. There was a dramatic improvement, and subsequent radiographs showed reduction in size of the consolidation with gradual clearing of lesions. By day 20, patient had decreased fever spikes, and hence we started the patient on chest physiotherapy. Swelling and pain, however, persisted in the right elbow, associated now with decreased range of motion. Repeat ultrasound was planned, X-ray was done, and we took an orthopedics consolidation, and this time we found osteomyelitis of right olecranon and ulnar bone with septic arthritis in the right elbow joint. Arthrotomy followed by debridement was done. Joint aspirate was sent for culture and sensitivity, which was again sterile. Finally, our patient became afebrile on day 28 of admission, and we continued IV antibiotics for another 10 days. By discharge, there
Swasti,
was gradual
2 minutes left, Swasti. 2 minutes.
By discharge, there was gradual clearance of lesions with only an ill-defined opacity in the right upper zone. Our patient was successfully discharged a happy face on day 40 with oral linezolid as a case of bilateral necrotizing pneumonia, etiology being bacterial infection due to disseminated staph infection. This is a timeline of the presentation of the patient with various interventions done and the duration of antibiotics. On follow-up, our patient was doing well. Weight loss during course of hospitalization was regained. Physiotherapy was started to improve the range of motion above the elbow joint, and we did an immunoglobulin panel on follow-up, which was normal. Necrotizing pneumonia is a morbid and potentially fatal complication of pulmonary infection characterized by progressive necrosis of lung parenchyma, the most common organisms being Staphylococcus aureus, Streptococcus pneumoniae, Klebsiella pneumoniae. This case demonstrates a novel manifestation of staph infection which can cause extensive lung necrosis and cavitation. Few learning points from our case can be: necrotizing pneumonia must be considered in a child with pneumonia who is sick despite appropriate antibiotic therapy for at least 72 hours. Fatal fulminant infections can present and need prolonged treatment even in immunocompetent individuals. This case also raises a question about the emergence of staphylococcal strains with PVL toxin. A multidisciplinary approach is must for a sick patient needing intensive care. It's not always possible to obtain a specific organism from routine blood culture, and we should look for other sources that may provide us with a clue to identify the offending organism. Non-invasive ventilation initiated at the right time can avoid need for mechanical ventilation and save many lives. Non-bacterial pathogens should also be excluded in such case scenarios. Thank you.
Thank you. Finished in time. Now over to judges.
In a grown-up child, when the pneumonia was not responding, was there a scope for atypical pneumonia?
Yes, sir. There was a scope for atypical pneumonia, but the thing is, in this case, we found a source like a pyoderma and multiple abscess, which suggested more as a staphylococcal etiology. Moreover, the chest X-ray we found a definite consolidation, which is again not in favor of atypical pneumonia. And the patient presented in shock, which again is more of like bacterial infection.
What was the reason of not being isolating staphylococcus in the initial samples?
So one can be, we did not, in repeat blood culture also we did not isolate, sir. And maybe because in periphery, patient would have received certain antibiotics. However, it is also seen that in necrotizing pneumonia, usually the maximum isolate is from pleural fluid. And since we did a pleurocentesis, we did not obtain any isolate from pleural culture report. But that could be because we took the sample from a single loculated area. However, from chest tube tip, we did isolate staphylococcus.
When you start suspecting a vancomycin-resistant community-acquired pneumonia?
When we are giving vancomycin, but even after at least 72 hours, the patient is not responding to vancomycin, then we should suspect that it's
What are the
resistant.
other drugs for vancomycin-resistant pneumonia?
So one is linezolid, that's the drug of choice. Other than that, teicoplanin can be given.
Any other drug which is available in India?
When sir said available in India, I'll become internal.
Dalbavancin, sir.
No, I will give the hint. The cheapest drug available in India.
Doxycycline.
No, ma. No, I'm not. I didn't.
Cotrimoxazole. Sorry, sir.
Cotrimoxazole, isn't it? Even cotrimoxazole.
Cotrimoxazole.
Yeah, Dr. Subramaniam, please continue.
So, firstly, what I wanted to know is, can you tell me the pathology in this child and link it to the organism? For example, the toxins and enzymes released by the organism and the pathology that you are seeing in this child. One by one.
So the pathology here, the cause for necrotizing pneumonia can be hematogenous spread of the.
No, I will give a start for you. Pneumonia is because of staphylococcus. Agreed. But after pneumonia, there is something else that happens. What is that the staphylococcus has got, which other organisms do not have, that makes it devastating?
So staphylococcus produces various virulent factors like pantone-valentin leukocidin, it's a toxin, gamma hemolysin, alpha hemolysin.
One by one, you tell me
these
what
toxins.
No, one by one, what PVL has caused in this child?
So PVL is known to cause skin and soft tissue infection. Along with it causes necrosis of the lung parenchyma. Okay. Most likely this is the cause which it caused it could have caused vasculitis. We also found evidence feeding vessel site that could be suggestive of a septic emboli because of vasculitis, which will activate the coagulation cascade and cause obstruction that will lead to necrosis.
You drop the PVL. Any other?
Hemolysin toxins, alpha hemolysin, gamma hemolysin.
No,
they can cause.
Is there any features in this child related to that?
So one can be serosanguinous fluid that we obtained.
Okay.
Other than that, anemia was there in this patient.
Okay. Next, any other? What is responsible for pneumatocyl? Which part of the
PVL can cause pneumatocysts.
Huh?
PVL can cause pneumatocysts.
PVL, one, any other enzymes, toxins? Okay, can you name some enzymes from staff? Sir. Difficult, huh? You are getting into difficulty.
Coagulase.
Okay.
Coagulase.
What does that can cause?
So coagulase can cause formation of cavities and necrosis, and it can
Okay.
Sorry, sir.
My next question is no, it doesn't matter. I think what I would request you after you go home, take microbiological clinical correlation. Did you understand my question? That was what I was asking, because if you understand the microbiology, then you know what are the clinical features of staph. The next question which I wanted to quickly ask, Gaba sir, you tell me if we are overshooting.
1 minute left, sir.
1 minute. Then I will leave it to Rawat. But before that, I would ask a last question to you. Now, why the blood cultures in staphylococcal infections will be invariably negative, and sometimes even the culture from empyema will be negative?
So in at least
isn't it? Yeah.
Yes, sir. So it has been shown that in around most of the cases, we find blood culture to be negative. Around 30% only we find that positive. Maybe because rampant use of beta-lactam antibiotics in the peripheral setups, that can be a cause why blood culture is
Fine. Fair
usually
enough, but I
negative.
will tell you the answer, although I'm not supposed to tell because there are viewers and students. See, this is a locally devastating bacteria than a bacteremic bacteria. See, bacteremic
Yes,
bacteria
sir.
means the
Yes,
one
sir.
which grows in the cultures. This is a non-bacteremic
Sir.
type of organism which is locally devastating, isn't it? So that's the point.
Yes,
Rawat
sir.
sir, you are over to you.
Yes. Swastik, one observation which I have made is that you spent very less time in the history because your history was not at all informative because it was not clear which is the primary event, whether primary event was respiratory problem or primary event was access. Because by the history it should be very, very clear that what, because you are trying to tell me problems in two different systems, skin and soft tissue and respiratory. So you spend very less time in history and you were not informative regarding what is the primary pathology, whether the disease started with respiratory and went on to skin and soft tissue or soft tissue to skin. For first thing.
So, in the pardon me, sir. So, in the initial slide where I showed the timeline, the initial presentation was for 8 days duration of skin and soft tissue swelling, and only 3 days prior to hospitalization, the patient developed respiratory complications. In the past history, there was a history of pyoderma 15 days back, as I mentioned. So it suggests that there was initially a peripheral site from where the organism could have spread and caused the respiratory complication.
Yes, so I think it should have been in a more detailed time. Like whenever you give history, you should spend more time in history just trying to make things clear that what is the timeline and how things, because you spend very less time and then you jump down to the examination. So it was not very, very clear. Then next, when you try to manage this
Sorry,
child,
sir.
you had two problems, one in soft tissue and bone and joints, and one problem in the respiratory. Now you know that the source is from the skin and bone and joint. So along with treatment of your respiratory problem, your more effort should have been to source control of the basics of the infection. Because if you go on treating only pneumonia and if you don't treat the abscess, if you don't treat the osteomyelitis, your pneumonia not going to respond because source is not getting treated. So I think when you manage this child, your primary disease was in the bone and joint and the soft tissue. So your more effort should be there trying to treat it surgically, drain those pus, trying to obtain a good sample, send it to a culture because you isolated Staph aureus quite late in your management. Whereas this should have been done very primarily right on day or two because your disease started from skin and soft tissue. So you spend a
Sir.
lot of time on respiratory problem, and then ultimately, then you when you went to soft tissue, then you isolated Staph aureus, and then you change your antibiotic from
Yeah.
vancomycin to.
Swati, can you respond to Rawat sir's query?
Pardon, sir.
Respond,
Yes,
sir.
sir. So on the day one of presentation itself, we drained the gluteal abscess and we did send the pus for culture sensitivity, which was sterile, sir. We did not isolate Staphylococcus aureus from pus culture or from joint fluid aspiration. Rather, the organism was isolated from the chest tube tip culture, sir. Secondly, sir, we started the patient on injection clindamycin because of skin and soft tissue infection by 48 hours of admission when the patient was not responding to broad spectrum antibiotic and vancomycin. That is why, so we did address the skin and soft tissue infection part. Along with, we started non-invasive ventilation for the respiratory complications.
Fine. So I think so, Swati, in a lighter vein, what you could have told is that the anesthetist did not give fitness for sedation and analgesia till the lungs recover, which is the usual story in most of the institutions. No, in a lighter vein. So you can't afford to tell that answer, but you could have been, practical. We wanted to drain, but they didn't allow to drain. Fine. And all the pages are smiling, the way you are struggling around about getting the fitness for surgery and all. There was anemia as well, isn't it?
Yes, sir. We did
There
give
were a
tight
lot of
discipline.
limitations for knocking down this child onto drainage, perhaps, and that led to osteomyelitis as well. So fair enough. I don't know the ground reality, but in many times we go back to the retrospectively to the case, and we felt that Monday we would have done that, Tuesday would have done that, but it is already Thursday. It does happen in practice. Don't worry. Fine, fair enough. I think can
Yeah.
we go to the next case?
Yes, sir.
Yeah.
I think we'll go to the next case code number
Swati, and
19.
I would request all the participants to immediately stop sharing the screen as soon as you finish the presentation. Next one.
Yeah. Case code number 19.
Yeah, Krishna.
Krishna will start at 11:27. You share your screen, Krishna, and we start now. First, unmute yourself, Krishna. Unmute yourself.
Hello, sir.
You go to the slides.
Start, Krishna.
Sir, am I audible?
Slideshow.
Am I audible, sir?
You are
Yes.
audible, but you start the slides.
Yes, sir. Good morning, all. Today I am going to present a case of pneumonia in an 8-year-old girl child from Odisha.
Krishna, what you do is go to the slideshow so that it comes as a full screen.
Yes, sir.
Yeah.
Yeah, that's right.
Good morning, all. Today I am going to present a case of persistent pneumonia in an 8-year-old girl child from a tribal belt of Odisha. A 8-year-old girl child admitted to MKCG Medical College of Odisha with complaints of fever, cough for 1 month, weight loss for 1 month, and occasional hemoptysis since last 1 month. The patient was apparently all right 1 month back. To start with, she developed fever, which was low grade and intermittent in nature. The fever was associated with productive cough. The sputum was scanty and sometimes blood tinged without any odor, and there was no diurnal variation or positional variation in cough. The child also had history of loss of appetite and weight loss since last 1 month, but there was no previous weight record. Was not having any history of chest pain or breathing difficulty. The child was evaluated and treated in hospital with diagnosis of pneumonia with the confirmed radiological findings, but the symptoms didn't resolve. As the radiological shadow persisted, despite of multiple courses of antibiotics, she was MKCG Medical College and Hospital for further evaluation and management. There was no history of any chronic illness in past, no history of contact with tuberculosis, and the child was neurodevelopmentally normal child, reading in class 4 with average academic performances, and she was introvert in nature. The child was immunized as per age, and BCG scar was present. She had no history of any drug allergy or food allergy. She was a second-order girl child with 3 more siblings who are doing well. Parents are healthy and with low socioeconomic status according to modified Kupusami scale. They use well water for drinking purpose, and they were having no sanitary latrine. On examination, the child was found, at the time of examination, the child was conscious and oriented to person and afebrile with temperature of 98.4 degree Fahrenheit in axilla. Pulse rate was 108 per minute, which was regular in rhythm and normal in volume, and all the peripheral pulses were well palpable. Respiration rate was 29 per minute, which was tachypnea for that age. SpO2 was 98% with room air, and BP was normal for the age. The child was having thin build, 20 kg, and height of 110 centimeter, BMI of 16.5, which is low for the age, In head-to-toe examination, there was no significant abnormality detected in the child except pallor. There was no icterus, no cyanosis or clubbing or lymphadenopathy. On respiratory system examination, on inspection, the child was having no chest wall deformity, and chest wall was bilaterally symmetrical, and movement was equal with respiration. On palpation, mediastinum was found to be central in position, by normal position of the apex pit and a normal central trachea. There was no localized tenderness over any area of the chest, and chest wall movement was found to be diminished in the right side of the chest. On percussion, it revealed a dull note on percussion in the left side of the chest, left lung anteriorly as well as posteriorly, and also same dull note was noted in the right side in the inframammary. On tidal percussion, the dull note changed to regional. On auscultation, there was decreased brace above areas and presence of crepitation in the right inframammary and infraxillary area, with vesicular breath sound were heard all over the all other areas. On abdominal examination, there was hepatomegaly with liver palpable 5 cm below the right costal margin with liver span of 10 cm. Liver was non-tender and firm in consistency, and surface was smooth and border was rounded. Spleen was not palpable. There was no other palpable mass in the abdomen. CVS and CNS examination revealed no other abnormalities. So, to summarize the clinical findings and history, a 8-year-old girl child admitted to our hospital with complaints of low-grade fever and productive cough, weight loss and loss of appetite, and occasional hemoptysis since who has received multiple courses of antibiotics within the last 1 month. The child was not having any chronic diseases or contact with tuberculosis or history of similar illness in past, immunized as per age, and neurodevelopmentally normal child. On examination, the child was found to be tachypnic and some pallor was there, and BMI was low for the age. On respiratory system examination, mediastinum was central in location. Dull noted percussion was noted in the left side as well as in the right side in the lower part, and decreased air entry was found in the above areas. On abdominal examination, there was hepatomegaly with liver span of 10 cm with other system examination within the normal limit. With the above history and clinical findings, we got a provisional diagnosis of pulmonary tuberculosis and we went to investigations. In blood investigation, hemoglobin was low. It was 7.9 gram per deciliter. TLC was normal. TPC was normal. With in DC, we found eosinophil count of 6%. In biochemical parameters, it was normal. RI50 was normal and liver was normal with serum protein of 7 milligram per deciliter. Sickling was negative for the patient, and as we suspected pulmonary tuberculosis, we went for sputum and gastric aspirate AFB and CBNAT, which was found to be negative. On radiological examination, X-ray of chest found homogeneous rounded opacity in the left upper and the middle zone with pushed up diaphragm in the right side. USG of the thorax and abdomen revealed a loculated collection in the left and the right lung with hepatomegaly and cyst in the abdomen. In the thorax, there was multiple hydatid cysts in the left upper and the right lower lobe, and CCT of the abdomen found 2 hydatid cysts in the liver. Here is the X-ray. We are getting a homogeneous opacity in the left side involving the upper zone and the middle zone, and also there is a pushed up diaphragm in the right side. This is the CCT of thorax and abdomen. We are getting a opacity in the lungs, bilateral lungs, as well as the liver. This is a CCT report of the abdomen. It is showing 2 hydatid cysts in the right lobe of the liver. And CCT of the thorax found multiple. The number was 3 hydatid cysts in the left upper lobe and the right lower lobe, with rupture of the cyst in the right lower lobe. There was minimal pleural, right pleural. With this history, clinical examination, and radiological findings, we from the history and we concluded the case to be multiple hydatid cysts involving the right lobe of the liver as well as the right and left lungs. From this, learning point is Any case of persistent lung shadow cannot be always due to pneumonia. It can be due to other etiology like hydatid cyst. Thank you.
Subramaniam sir, over to you, the judges.
Krishna, as
Yes,
soon
sir.
as you see the first chest X-ray itself, will you feel that this is or this is not a pneumonia?
Sir, we can will suspect this as a pneumonia case.
You think it is pneumonia?
Yes, sir.
This X-ray is given to you in your post-graduation examination.
Yes, sir.
Will you see pneumonia with such nice borders?
No, sir.
Then what you call that pneumonia with nice borders called as? There is some name for that. And the name goes with the shape.
Round pneumonia. Sir.
Round pneumonia, no? Will the round
Yes,
pneumonia
sir.
appear like this? Anyway, fair enough. The second question is, when you see a shadow like this, for example, on an X-ray, what is the next investigation you will do? I'm coming to investigation only. Anyway, Rawat
Yes,
sir
sir.
will ask history. So I will come to investigation. Now, I will just finish the concept from this. Suppose you see a shadow like this. Agreed. Pneumonia or non-pneumonia. You wanted to take pneumonia. I want to take it as non-pneumonia from the very first X-ray. The rest of the lungs being so clear.
Yes, sir.
Correct. Now, what is the
Yes,
next
sir.
investigation you will do? Is it CT or something else you can do?
Sir, ultrasound of thorax you can do.
Just no. What does that? What did that reveal?
Sir, in cyst, it can detect the cyst in the thorax.
No, fine now. So why do you need CT then? So my
Sir,
question
to
is,
differentiate between cystic and multilocular type, we can use CT scan.
that is only in empyema. Otherwise, why do you need?
Sir, to differentiate two types of echinococcosis infection, as we are having cystic and alveolar type, we can use CT to differentiate between the two.
No, okay. The ultrasound also detects cysts in the liver.
Yes, sir.
So then the diagnosis is over. It has to be. Do you think there is a cyst in the liver and cyst in the lung? You think they are different cysts or the same or same pathology? I mean, same cause.
The
Probably.
same cause.
Same cause.
Yes, the
No.
same cause.
Then the diagnosis is
Yes, sir.
almost over. Correct?
Yes,
Will you
sir.
attempt to puncture and aspirate?
No, sir. No,
Why?
sir.
Why?
It can cause anaphylaxis.
It can cause anaphylaxis. Fair enough.
Yes, sir.
And then I think I will allow Dr. Sharmaji and Rawat sir to ask questions because I've asked one or two.
Rawat sir, please.
Yes, Krishna, a
Yes,
child
sir.
who has got respiratory symptoms since past 1 month, in
Yes,
your
sir.
negative history, you will not ask any history related to GI symptoms because a child with a long respiratory symptom, he could have cystic fibrosis. In your history, I couldn't find
Yes, sir.
any history which was suggestive of negative history of any GI involvement. So I think you missed that,
Yes, sir.
right?
Sir.
Then in your DD, your only DD was tuberculosis. Yeah, your only diagnosis was tuberculosis. So how it is possible? What are the findings or suggestive of tuberculosis? Why are you sure this child is having only tuberculosis and no other thing? Because you
Sir,
only
from the
mentioned
history,
one diagnosis. I think it is tuberculosis. How could you could be so sure?
sir, from history, it was a long history with fever and cough for 1 month, and there was history of loss of weight and appetite since last 1 month. So we suspected this is the endemic area for tuberculosis. So we suspected tuberculosis in that patient, and also the patient didn't respond to any antibiotics in the last 1 month.
So he could have many other things. He could have some foreign body, or he could have immunodeficiency. So many things could have. So your DD was only tuberculosis. You are very sure that it could have anything else. So I think whenever you have a child with any respiratory, you have to make a list of at least 4 or 5 diagnoses. Then only you can go ahead. Your diagnosis was only, I can only think of only tuberculosis. So I think whenever you have a list, you make at least 4-5 diagnoses so that you can come to the proper conclusion. Then the third question is that your child had respiratory rate to 29. So do you think that 29 at 1.5 years is tachypnea? What is the normal respiratory rate at 1.5 years?
Sir, the age is 8 years, sir.
8
The
years.
girl's age is 8 years, sir.
Okay, so what is the normal respiratory rate at 8 years?
From 16 to 20.
Okay, thank you.
No, Sharmaji sir, before you would come in, I wanted to ask Krishna, at this stage you were thinking of tuberculosis. Is this X-ray at least suggestive of tuberculosis?
No, sir, not suggestive.
So fine, fair enough. Sharmaji sir, you can go ahead.
What is the other differential diagnosis of this shadow? Can it be lung?
Round pneumonia and cyst in the lung or lung abscess. And
Can it be lung abscess?
Any other congenital?
Yes, sir, congenital lobar emphysema can be.
No, not emphysema. Congenital lobar emphysema.
The cyst is fluid filled or air?
It can be CCAM or CPAM, not CLE. Okay. Fine. Any other DDs? Because I told one answer, at least other one. Anything where, it gets sequestered and then some manifestations happen?
So pulmonary sequestration.
Now that I have told you, given you some hint, Sharmaji sir can smile and tell me the different types of sequestration, intralobar and extralobar, and which is likely in this particular patient with this shadow.
Can this be an artifact outside the thorax?
No, yeah. So involving the liver also.
Can the lateral X-ray chest will help you in some way? What was the mistake you committed in making a diagnosis of tuberculosis in this child? Was the symptom suggestive of tuberculosis?
So there was history was cough and fever for 1 month with.
What kind of fever for tuberculosis? What kind of cough for tuberculosis? And what kind of weight loss? There are definite criteria for these.
Yes, but so last previous weight record was not there with us.
It has to be a documented continuous fever more than 38 degrees. It has to be an unremitting cough and the weight loss 3 months.
Yes, sir.
Documented. So there was nothing. The radiology was also not suggestive. So I think
yes,
tuberculosis is a far-fetched diagnosis in this child. Okay, thank you.
I think you have fairly done well. You can relax, but you stop sharing the screen.
Yes, sir.
Before going to the next case, a small announcement. We are lagging behind by 12 minutes, sir.
Totally.
Sir, totally. Overall.
That's fair enough. No problem.
Fine. So we'll go to the next case code number 20. Dr. Krishna, you please stop sharing the screen.
Yes.
I think Srishailam, we will ask questions after they stop sharing the screen. No, but the point is sometimes you may have to ask some question related to slides, so let them be on.
Fine, fine.
Again, they have to start sharing the screen, so it makes sense.
Sandeepan, are you ready?
Yes, sir. Just sharing.
Start sharing the screen. Once you start sharing the screen, your time will be started.
Sir, is my screen sharing is available? Can you see my slide?
No,
hello,
we're
sir?
not seeing a slide.
No. You are on mobile or you
No,
are on
sir.
iPad? Okay.
Now is it visible, sir?
No.
Hello, sir.
No.
No, I think what you do is Srishalam, you give him time. You announce the next contestant. You not waste time.
Okay, fine.
And then he can come back
Next.
again. Let him do all
Yeah,
the
next
exercise.
call upon case code number 21, Abhijit. Abhijit,
Yes,
are
sir.
you ready?
Yeah, Abhijit, you can start.
Sir. One sec. One sec, sir.
You take time, don't worry.
Am I audible, sir?
No, you Abhijit, you
Am I
take
audible?
time because you need time. You are audible, visible, very clear. Gaba sir,
Okay,
please
sir.
note the time, sir. 1 second, Abhijit. I will mute all
Yes, sir.
and then you unmute.
Okay, sir.
Now you unmute.
Should I start, sir?
Yes, please go ahead. Gaba sir, fine now? Sir, unmute.
Gaba sir, unmute कीजिए. Okay, I have the timer, sir. Let them
Yes,
start.
start 11:48. Abhijit, start now.
Okay.
Yes, sir. Good morning, all. Myself, Dr. Abhijit Bhai. I am going to present the case of a candid pneumonia in a child with severe acute malnutrition and rickets. A 3.5-year-old male child, third by birth order, born of non-consanguineous marriage, residing at Ganesh Colony, Pimpri, brought to casualty with a complaint of fever since 15 days, cough since 10 days, and difficulty in breathing since 2 days. Child was apparently all right 15 days back when he developed fever, which was insidious in onset, continuous, low grade, relieved partially on medication. After 5 days of onset of fever, child developed cough, which was insidious in onset, gradually progressive, with no diurnal variation, productive, associated with post-rescue vomiting. Child developed difficulty breathing since 2 days, which was gradual in onset, progressive type, present even on rest. There is a history of not gaining weight and unable to stand or walk even at this age. In past history, there no past history of psychological
Abhijit,
arrest or
1
female
minute, please
complaint.
hold on. Are you using two devices?
No, sir.
Some sound is coming. Fine, go ahead.
No, sir, I am not using. Okay. Past history, no history of hospitalization of similar complaints in past. No history of exanthelmus fever in past. No history of recurrent respiratory tract infection. No history suggestive of congenital heart disease. In antenatal history, mother was ANC registered at government hospital in second month of pregnancy, conceived spontaneously, received iron and folic acid tablets since second trimester. Also received 2 TT injections in 5th and 6th month. Child was full term. Normally, it was a normal vaginal delivery. Cried immediately after birth. The birth weight was 2.3 kg. Breastfed within half an hour after birth. There was no history of NICU stay. According to mother, 2 vaccines were given at the time of birth. In the development history, the gross motor milestones were achieved up to the 9 months of age. Currently, child can sit without support. Development quotient is 25%, but the fine motor, language, and social milestones are normal as per his age. In dietary history, child was exclusively breastfed till 9 months of age. Complementary feeding was started since 9 months. Breastfeed stopped at 15 months of age. Summarizing the diet history prior to the illness, the total calorie required for the baby is 1680 kilocalories, but the child is consuming 805 kilocalories. The total deficit of calorie will be 875 kilocalories, and total protein required for the calories is 19.6 gram per day, and he is consuming 12 grams per day, and the protein deficient is 7 grams.
Abhijit, are you using a Bluetooth device?
Yes, sir, I am using a Bluetooth device.
That's why that noise is there. That's why
Should
there's a
I
lot of
disconnect?
noise.
See,
All
I
others
will tell
are
you, we will
muted.
cancel this. I'm not able to hear anything. It is too much annoying and disturbing. You go to the next candidate. We'll come back to him. Abhijit, this is not acceptable.
Okay, sir. Sorry, sir. Sorry, sir.
You cannot make something innovative and new. You cancel this and we'll come back to him at the end lastly. You go for the next
Okay,
one.
sir.
Please don't trouble us with, there is so much of, we can't tolerate. I don't know
Yeah.
whether others
Okay, sir.
agree with me.
No, it's disturbing, sir. We are not able to hear also.
Okay,
So-
sorry, sir. I'm extremely sorry, sir. I will.
No.
I will reach.
These things you have to take care. Technical issues, we gave you
Actually,
time from
okay.
9:30 to check.
Yes.
And you are
sir,
not even using your video.
Okay, sorry.
No, you terminate now. I could not hear even a single slide of yours.
Okay.
You can stop this sharing
Stop
of the
sharing
screen.
the screen first.
Okay.
Yeah, you go to the next candidate.
33 number, code number 33.
If there is any technical issue,
Yes,
you
sir.
make them wait till the end.
Okay. Gopika, are you ready?
Yes, sir. I'm ready, sir.
Please start.
So once you start sharing your screen, we'll start the
No,
time.
is that only for me or for everyone? That disturbance.
No, it was there for everyone. That's why I prompted.
It was for everyone, sir.
Again, fine.
Sir, am I audible, sir?
You are audible, ma, clear.
I'm visible, sir?
Yes, visible and make a slideshow.
Yes, sir.
Your number is 33, correct? Yeah, start.
Yes, sir. My case presentation, code number 33, sir. I am Dr. Gopika Nair, sir.
Please start.
Start, Gopika, start. 11:52, right now.
Yes, sir. Good afternoon to all. I bring a case of an 82-day-old female child residing in Kittur, Belgavi, born to IT professionals. Informant is her mother and information is reliable, sir. 82-day-old female child presented to a PICU as a referred case with complaints of failure to gain weight since 1.5 months of age, difficulty in breathing since 10 days, persistent dry cough not subsiding with medication since 10 days, poor feeding and lethargy since 5 days, and fever since 4 days. History of presenting illness. According to the informant, 82-day-old female child was born out of a third-degree consanguineous marriage to a primi gravida with term gestation via normal vaginal delivery with 2.5 kg birth weight. Baby cried immediately at birth and was initiated with breastfeeding soon after birth. 4 hours following delivery, mother noticed that baby had poor suck and hurried breathing and hence was shifted to NICU for observation. Baby had an NICU stay for 22 days in view of breathing difficulty, not tolerating feeds, and yellowish discoloration of skin, treated with IV medications and oxygen supplementation through assisted device. Later, condition of the baby improved, but there was no weight gain and was discharged with nutritional supplements and oral medication for cough. At 1.5 months of age, she developed severe dry cough and hurried breathing, following which parents took the child to a nearby private hospital, where the child was admitted for 3 days, given IV antibiotics, nasal drops, and inhalation medication. General condition slightly improved, but she required twice weekly consultation for the same symptoms on OPD basis. At 77 days of age, child developed breathing difficulty while at rest, excessive cry and irritability, poor feeding, decreased sleep, following which she was taken to a local hospital, admitted for 5 days there, given IV medications and oxygen supplementation, but symptoms worsened and child developed high-grade fever, following which she was referred to our pediatric intensive care unit for further management. There was no history of fever, vomiting, or diarrhea during the previous admissions. There was no history of delayed falling of the umbilical cord, no history of persistent yellowish discoloration of the conjunctiva or skin, no history of bluish discoloration, forehead sweating, success cycle, no history of purulent nasal discharge or repeated fever, no history of constipation, passage of bulky, smelly stool, salty taste while handling or kissing the baby, no history of any viral infection in mother, no history of blood transfusion in mother during antenatal period. There was no history of any contact with TB patients. Development history, according to the mother, there was normal development up to age, and nutritional history, the child was breastfed on demand. Immunization history, child received at birth BCG, OPV, and hepatitis B1, and at 6 weeks she received DPT, IPV, hepatitis B second dose, Hib, and pneumococcal vaccine. Socioeconomic history, they belong to Kupasamy socioeconomic status scale upper class. On physical examination at admission to pediatric intensive care unit, the child was sick, drowsy, and lethargic. Peripheries were blue, and the child was looking pale. There was nasal flaring, subcostal retraction, intercostal retractions, and tachypnea. On primary assessment, the airway was open and maintainable. There was tachypnea, subcostal retractions, intercostal retractions. Saturation was 82% on nasal prongs. Capillary filling time was more than 3 seconds. Pulses were feeble. Heart rate of 152 beats per minute and cold extremities. There was no disability, no swelling, deformity, or rashes. On examination at PICU admission, the temperature was 101 degree Fahrenheit, heart rate was 152 beats per minute, respiratory rate was 72 cycles per minute, saturation was 82% on oxygen by nasal prongs, BP of 74 by 38 and a MAP of 50. On anthropometric examination, the weight was 2.5 kg, same as the birth weight, which was less than -3 standard deviation. The head circumference was 36 centimeter. The length of the baby was 52 centimeter, which was again less than the third standard deviation. There was pallor present, no icterus clubbings, lymphadenopathy or edema, but peripheral cyanosis was present. Head-to-toe examination, shape and size of the head was normal. AF was open at level, admitting 2 fingers. All other morphological features were normal, except that ribs were prominent and intercostal spaces were shallow. Systemic examination, positive findings in systemic examination. On inspection, there was flaring of ala nasi, intercostal, subcostal retractions, decreased movement of the right chest, palpation. There was chest expansion decreased on the right side. There was no tenderness of crepitus. On percussion, there was hyperresonant nodes on the right infraclavicular and the inframammary area. On auscultation, there was decreased breath sounds in the right side of the chest. Bilateral coarse crackles were present. On cardiovascular system examination, the capillary filling time was prolonged. Pulses were felt, were low volume, and S1, S2 was heard without murmur. Gastrointestinal system examination, there was no organomegaly, and central nervous system examination was within normal limits. Course in the hospital, infant presented to pediatric intensive care unit in respiratory failure, was intubated and ventilated. Circulatory compromise was corrected with fluids and inotropes, and preliminary investigations including blood culture were collected. Arterial blood gas analysis was done, which showed severe respiratory acidosis. Chest X-ray was taken, which revealed a right-sided pneumothorax and upper lobe or bilateral upper lobe opacities. ICD was put on the right side in view of the pneumothorax, started with empirical antibiotics, and oxygen supplementation was provided. Based on the preliminary investigations, a workup was done, keeping in mind the differential diagnosis of a congenital heart disease, a congenital lung disease, cystic fibrosis, immunodeficiency disorders, and finally an interstitial lung disease. In view of this, immunoglobulin levels were sent, which was found to be normal. A stool routine microscopy was sent, which was normal, and echo was done, which was again found to be normal. Preliminary investigation only showed an increase in WBC count, which was 25,000. CRP count was raised 18.2, and the electrolytes were within normal limits. Renal function test was within normal limits, and LFT was also within normal limits. Admission blood culture, there was no organism grown after 5 days of incubation. Endotracheal secretion culture was sent. It showed Klebsiella pneumonia, which was sensitive to tigecycline, ceftazidime, and trimethoprim sulfabactam. X-ray showed, this was the X-ray of the baby taken at 1 hour of admission. Right-sided pneumothorax was present, bilateral upper lobe opacities were present, and the bilaterally hyperinflated lung fields were present, and thymic shadow was visible. HRCT was done after 2 days of stabilization. Bilateral ground glass opacities with geographic distribution was found, and a mosaic pattern of the opacities more involving the lingula and the middle lobe was found. There was significant air trapping that was found in the hilar regions. The typical findings raise the suspicion of a childhood interstitial lung disease in the child, probably a neuroendocrinal hyperplasia of infancy due to the age of presentation. A differential diagnosis that we had kept in mind was congenital structural anomalies, immunodeficiency disorders, cystic fibrosis, congenital heart disease, interstitial lung disease, and symptoms and history and the clinical examination has had ruled out the previous ones, and we narrowed down our diagnosis to interstitial lung disease. Our diagnosis was neuroendocrinal hyperplasia of infancy with nosocomial pneumonia in respiratory failure. Treatment, oxygen supplementation, child was ventilated for 5 days, antibiotic was started empirically, and then after culture and sensitivity, we had changed antibiotic based on the culture, and ICD was put on the right side to drain the pneumothorax. Nutritional supplements were given, and IV methylprednisolone pulse therapy was given for 3 days, followed by oral prednisolone at discharge. On follow-up, child had improved, child had had weight gain, and due to the pandemic, we had a telecommunication with the parents. A small discussion, neuroendocrinal hyperplasia of infancy is a recently reported rare childhood disease, first noted in 2005. Almost 116 recorded cases have been present since then. Pulmonary neuroendocrinal cells function as oxygen sensors and chemoreceptors, serving complex roles in a variety of developmental and disease-associated contexts. NAHI insidiously presents in first year of life, incidence and prevalence of which remains unknown. Clinical features include when to suspect a chronic tachypnea, hypoxemia, failure to thrive, and respiratory failure in a child less than 1 year. Though lung biopsy has been the historical gold standard, a non-invasive workup, as in our case, an HRCT can be helpful in diagnosis and is popularized of late. From my case presentation, we would like to highlight that a high index of suspicion for neuroendocrinal hyperplasia of infancy should be raised in any infant presenting with frequent hospital admissions and antibiotic administration. As in our case, diagnosis can be ultimately achieved using non-invasive HRCT so that it does not increase the burden on the family. And lung biopsy and histopathology, though remaining the gold standard, a non-invasive method like HRCT is a sensitive tool up to 78%, and the specificity in a competent setup, it's 100%. Thank you, sir.
Perfect 10 minutes.
Thank you, sir.
Over to Subramanian sir and the judges, Rawat sir and Sarma sir.
Dharmaji?
Yes, sir. Can you tell me how you have ruled out the immunodeficiency by doing an immunoglobulin at such a small age?
Yes, sir. We had inquired in the in the birth history whether whether there was delayed falling of the umbilical cord, repeated rashes, infections, or any the hospital admission for.
How the immunoglobulins rule out immunodeficiency at this age? They are maternally derived immunoglobulins.
Yes, sir, but the titer IgG, IgM titer was very less, sir.
I don't think that is the modality of investigation. Okay, how you ruled out alveolar proteinosis?
Sir, pulmonary alveolar
picture is almost the same. The pulmonary alveolar proteinosis and the neuroendocrine hyperplasia, they are almost the same on HRCT. How you ruled out that?
Sir, the hilar opacities and the air trapping in the neuroendocrinal hyperplasia are not seen in pulmonary alveolar proteinosis, and the upper and the middle lobar opacities that are significantly found in neuroendocrinal hyperplasia. In pulmonary alveolar proteinosis, they are seen widespread, sir.
I think it needs to be ruled out rather than putting it empirically as neuroendocrine hyperplasia. Dr. Subramania, please.
I'm just asking you, why not this being bronchiolitis obliterans?
Sir, there was no fever episode other than the admission one, which was the child was admitted previously in a hospital setup, sir, and from there the child was referred. Previous admissions, previous episodes of OPD visits, the child did not have any fever, sir.
No, fever is not there in bronchiolitis obliterans, no. I'm just asking you.
Sir,
so you want to rule out in a less than 3-month-old baby presence and absence of fever? Is that the way to go about bronchiolitis obliterans?
No, sir, it can be without fever, sir.
Okay.
Sir, and the hypoxemia, the persistent hypoxemia, sir, and retractions were too much. It was not consistent with that of bronchiolitis obliterans, sir. The child was in failure to thrive. There was the weight had not improved from that of the birth weight, sir.
My next question is, can this be COVID?
Sir, pediatric COVID, sir, it might not present with a respiratory distress in this infant age group, sir. It is usually after the COVID, acquiring the COVID infection, the child might present in various other modalities other than respiratory distress like this, sir.
Okay, fine, fair enough. No, I was just trying to pull you out to see if you can commit to that. Can you tell me the types of interstitial patterns that you see on CT when it comes to ILDs?
Sir, interstitial pattern, sir. Sir, in CT, sir.
In CT, yeah. See, interstitial pneumonia is a CT diagnosis, isn't it?
Yes, sir.
Yeah. So therefore,
sir, it can be diffuse interstitial pattern, sir, and interstitial lobar pattern, sir, and ground glass opacities. Then, sir, yes, sir.
Reticular, nodular, isn't it? Miliary,
yes,
miliary. What about miliary?
Sir, miliary pattern also presents, yes, sir, similar presentation, sir, but more to the end, so peripheries of the lung field, sir, not in the hilar.
What has caused pneumothorax in this child?
Sir, pneumothorax, this was one more concern we had, sir. The child was admitted previously. So there might be a super added nosocomial infection that the child would have acquired. And one more thing is these hilar opacities have air trapping, which is significant in neuroendocrinal hyperplasia of infancy. And this air trapping would have caused the one of the air trapped areas would have had a burst, and that would have caused the pneumotocele, sir.
Fine. Rawat, sir.
Yes, Gopika, one observation and one question. Whenever you present history, because as you know, history is the most important aspect of case presentation.
Yes,
so
sir.
when you presented your history, you presented the presenting complaint, and then you straight away jumped over to birth history and all those things. So whenever you are going to present your history, first you have to work up the presenting symptoms in detail so that we understand that what is the genesis of the disease, and subsequently you have to go to the birth history and all those things. So what you did was you presented the presenting complaint and straight away you jump to the birth history, birth weight, all those things. So it was really not clear that what was the sequence of event and how the disease progress. So I think this probably next case presentation, you must remember that whenever you present your presenting complaint, work up the complaint, give the entire details of the complaint for which the child has come to you, and then go on the further details.
Okay,
my only question to you is that,
yes,
was the child in shock?
Yes, sir. The child was in shock, sir. Due to the child had traveled from this private hospital. The child had traveled almost half an hour before reaching to a pediatric intensive care unit. It was the starting of the COVID time, sir. And when the child came, there was peripheries were blue. Perfusion was more. CFT was more than 3 seconds, and pulses were very feeble, sir. We did the pediatric primary assessment and then stabilized according to the pediatric acute life support, and then started on treatment, sir.
So in your final diagnosis, you told it is a child with respiratory failure. You never mentioned shock anywhere, because if you mention shock, then it itself is a very serious issue. So in your diagnosis, you have only mentioned respiratory failure. You have not mentioned shock.
Okay, sir.
Okay, thank you.
Thank you, sir.
Okay, sir, we have exceeded 1.5 minutes. I think, can we go for the next case? Thank you, Gopika. The next
is next. What is the number next?
Next is Harshini, 36, 38, 35. Sorry.
Ashni, start now. Your time starts now, 12:10. Okay. For 10 minutes, you have to complete.
Sir, am I audible, sir?
What's the code
Yeah,
number?
you are audible. You are audible.
Code number?
Sir, 35, sir.
Code number?
35, sir.
35.
Sir, can I start now?
Yeah, go ahead. Go ahead.
So, a very good afternoon to everyone. So, today I present a case of 7-year-old female child hailing from Bangalore who belongs to class 1 of socioeconomic status according to modified Kuppuswamy classification, and the history being reliable as the informant is the well-educated mother. So, on chief complaints, child presented with fever since 7 days, cough since 3 days, and fast breathing since 1 day. So on his presenting illness, previously healthy child presented with fever since 7 days, which was acute onset, progressive, high grade, continuous type, relieved on taking medication, recurring every 4 to 6 hourly, associated with generalized body ache, not associated with chills and rigors, and cough since 3 days, which was acute onset, progressive, productive with scanty sputum, white in color, non-foul smelling, non-blood stain, no diurnal variation and postural variation of cough, with history of post-acid vomiting present, and fast breathing since 1 day, which is not relieved on rest, and it is associated with decreased oral intake since 1 day and decreased activity since 1 day. So there was no history of noisy breathing like wheeze or stridor, no history of pedal edema, no history of cyanosis, no history of foreign body ingestion or inhalation, accidental foreign body ingestion or inhalation, no history of running nose or coryza-like illness, no history of altered sensorium, no history of contact with tuberculosis, no history of chest pain, or no history of symptoms pertaining to any other system. In the past history, there was no similar illness in the past, no history of past episodes of hospitalizations, no history of diabetes or contact with tuberculosis. So on birth history, in antenatal history, the mother was booked case with normal antenatal scans, immunized against tetanus and was on iron and folic acid supplements, normoglycemic and normotensive throughout the pregnancy. And on natal history, born by full-term normal vaginal delivery with normal birth weight of 2.8 kgs, baby cried immediately after birth and there was no NICU admissions. And on postnatal, child was exclusively breastfed for 6 months. On developmental history, all the milestones in all domains are attained appropriate for age. There was no history of regression or delay in milestones. In nutritional history, in the pre-illness diet, there was no calorie deficit. And in immunization history, immunized appropriate for age and private hospital according to IAP immunization schedule. Child has also received pneumococcal conjugate vaccine and influenza vaccines. Records have been reviewed. So on personal history, child consumes vegetarian diet and bowel and bladder habits are normal and regular. On family history, child is a firstborn child to non-consanguineous marriage with maternal age being 28 years at the time of birth. There's no history of allergy or asthma in family, no history of any chronic illness in family, no history of similar illness at present in among other family members, no history of smoking in family members. So on summarizing after history, here is a 7-year-old child who is completely immunized, developmentally normal female child presenting with symptoms suggestive of acute respiratory illness likely to be community acquired pneumonia. So I would like to go to examination. Child was lying supine on couch, conscious, alert, responding to commands. Pulse rate, child had tachycardia, that is 120 per minute, regular rhythm with BP being normal 100 by 66 mm of Hg, with good perfusion, that is capillary filling time less than 3 seconds. Child was febrile, 101 and saturation was around 92% in room air. There was no history of pallor, icterus, there was no evidence of pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema, and there were no neurocutaneous markers, and height was at 50th centile and weight was at 25th centile according to WHO growth charts. So considering the history, so I would like to examine the respiratory, as we have summarized that there is an involvement of respiratory system, I would like to consider the examination of respiratory system. Upper respiratory tract was normal on examination. In lower respiratory tract, the positive findings was child was tachypneic, that is 55 per minute, thoraco-abdominal type of breathing with mild subcostal and intercostal retractions, which is a clinical clue for lung parenchymal involvement. And on palpation, there was decreased movements on right mammary region, infrascapular region, as well as the right infraaxillary region with increased vocal fremitus. And on percussion, there was impaired resonance or dull note in the same regions. And on auscultation, there was decreased air entry in the same regions along with bronchial breathing, crepitations in right mammary, right infrascapular, and right infraaxillary region. Other systemic examinations were normal. So I would like to consider the diagnosis community acquired pneumonia, mainly involving the right lower zone. So how did we manage this child? On day one, when child presented, child was already suffering with 7 days of illness with fever, cough, and fast breathing, which was in recent onset. So we did the routine investigations where CBC was absolutely normal and CRP was elevated, that is 15.8. Bun creat was normal, and X-ray showed right lower zone consolidation with minimal symptomatic effusion. So USG was done on the same day to rule out any septations or loculations. Child was started on IV ceftriaxone, and as child was 92% in room air, so child was started through face mask and supportive care was given. So on day 3 to day 5, there was the issues where the child had worsening in the respiratory distress and the high grade fever spikes were not responding to the antibiotics. And CBC showed lymphocytic predominant mild leukocytosis. And when we repeated the X-ray, there was increasing consolidation where the minimal pleural effusion progressed to moderate pleural effusion on the right side. So we upgraded the antibiotics to piperacillin, tazobactam, clindamycin, and vancomycin. CT scan was also done as there was worsening respiratory distress. It confirmed the X-ray findings, but there were no empyema. So on day 4 to day 5, what happened due to worsening respiratory distress? We sent an investigation respiratory panel from a nasopharyngeal swab, which revealed as etiological agent pneumonia. So we were happy that we identified the right bug so that we can start the child on right drug. So we stopped other antibiotics and we started on azithromycin as other cultures were sterile. So we started the child on azithromycin. So we were happy and we were waiting for the clinical improvement of the child. So on day 5 to day 7, as we started azithromycin, even after 48 hours,
you have 2 minutes to go.
Yes,
2
sir.
minutes to go. Yeah.
Even after 48 hours of starting azithromycin, child did not show any clinical response. There was worsening distress and clinically there was no response to azithromycin. Repeat USG showed right lower zone and also which has increased to mid zone consolidation with bilateral pleural effusion. Right was more than left. So to relieve the distress, we had to do an ICD insertion on day 6. So mechanically drainage, so there was decrease in the respiratory distress, but still there was persisting high grade fever spikes. So what next? We were all puzzled. So there was progressive increase in the CRP, which was on the day of admission, that is 15, and on day 7 it was 63. There was progressive increase in the CRP. So what next? So we had sent pleural fluid analysis where pleural fluid was sent for pneumonia panel for PCR analysis. That also double confirmed our etiology as Mycoplasma pneumonia. So we were puzzled. We identified the right bug and we started the child on right drug, but still there was no clinical response in spite of 48 hours of targeted treatment. What next? So as a postgraduate student, when we have identified the etiological agent as Mycoplasma pneumonia, I had to go back after thorough reading of Nelson chapter of Mycoplasma pneumonia. I had a learning point in this case, that is, I realized that there is a rare possibility of macro Mycoplasma pneumonia, which is an atypical organism which can atypically present as specific lobar pneumonias like other typical bacterial pneumonias, with large pleural effusion and with no prior cardiopulmonary diseases or any immune diseases in this child. So finally, On treatment on day 9, we started the child clinically suspecting macrolide resistant mycoplasma pneumonia. We started the child on doxycycline. So the child showed dramatic clinical improvement by after 3 days of ICD, there was nil drain. So respiratory distress improved, fever spikes. Almost after 78 hours, child was afebrile, air entry improved, clinical condition improved, and child was discharged with total course of doxycycline for 14 days. On OPD follow-up, child was absolutely fine. So this is how the child progressed. At the admission, there was only involvement of lower zone. Then the child worsened with lower zone and mid zone involvement along with pleural effusion, and this was during the drain placement that the child had resolving radiological features. So that's why I titled this presentation as right drug, and right drug is very important. And challenge in this case was the atypical presentation of a atypical organism. So as a part of discussion all through the case, I've discussed the atypical presentation of Mycoplasma pneumonia. So the typical presentation would be the incubation period varies from 1 to 2 weeks. And in the clinical illness, especially more than respiratory symptoms, it starts with fever, malaise, sore throat, and cough starts as the fever starts coming down. As we can see in the graph, it can last up to 4 weeks, and along with the cough there are respiratory signs like expectoration, scanty sputum, dullness and rales, and culture remains positive throughout. In the convalescent phase, after 4 weeks it comes down, and these are the radiological findings which predominantly involvement, interstitial involvement. So this is the typical presentation of Mycoplasma pneumonia, which was not there in our patient. That was a more learning point. Any common pathogen, not only
You have to
the
hurry up.
yes,
Time
sir.
is up. You have to hurry up.
Yes, sir. Thank you, sir.
Over to judges.
Over to judges, sir.
Dr. Subramania, please.
Yeah, Harshini, congratulations. Can you stop sharing the screen?
Yes, sir.
Yeah.
Yes, sir.
Is atypical pneumonia because of a single organism or many organisms?
So many organisms, sir.
Fair enough. Now I'm just coming to that point.
Yes,
Now
sir.
I'll come to a couple of points in this. Anyway, Rawat sir will take you on history. So therefore I'll come on to a couple of points. What would be the reason for non-response to azithromycin?
So like causative agent would be macrolide resistant Mycoplasma pneumonia, sir.
How? What is the mechanism of resistance to?
Sir, mutation in 23S subunits, 23S RNA, so that causes macrolide resistance.
So that's one. Now
Yes,
the
sir.
second question is, it's a 7-year-old child. If it doesn't respond after 48 hours in a pneumonia,
Yes, sir.
with a bit of effusion, will you go staph way or will you go atypical way? How will you decide at that point of time? Because you went through the staph and then came back to atypical. That's why I'm asking.
Yes, sir. Sir, actually in this age group, mycoplasma is more common, sir.
So then why you added piperacillin tazobactam with vancomycin, but not added azithromycin and waited for a long time and then got some culture, etc. What was the need? Right away add macrolide.
Sir, actually,
You see, somebody has managed. You need not defend it. Would you agree or disagree?
Sir, actually disagree, sir.
Tell me, why do you disagree? I mean, with the management or with me?
Not with you, sir. Like with the management, I would have added azithromycin earlier, sir. Considering the increased incidence of Mycoplasma pneumonia in this age group, sir. But one thing was typical lobar consolidation was there, no, sir. So that is little rare presentation of atypical
That's
pneumonia.
where you are into trap.
Yes,
so,
sir.
but effusion is it common or uncommon in? No, any other hematological clues that you had?
Sir, there was no hemolytic anemia, sir.
No clues whatsoever.
No, sir.
No, why the atypical pneumonias do not respond to your piperacillin, tazobactam or ceftriaxone? This is a basic question. I'm sorry.
Yes, sir. Because they don't have a cell wall, sir.
Fair enough. Fine. I will hand it over to Sharmaji and Rawat sir.
What was the treatment history of this child before coming to you? Probably there you could have guessed the point.
Sir, actually, they did not use any antibiotics, sir. Child was only on like considering normal URTI. So they had given only paracetamol and antihistaminic syrup, sir. Other than that, they haven't used any antibiotics, sir.
Then why you have not tried amoxicillin? Somebody, not you, amoxicillin to begin with for community-acquired pneumonia, and then switch over to added the azithromycin as Dr. Subramania had said. That was the WHO recommendations.
Yes, sir. That is actually ideal management, sir. But institutional wise, we.
Okay. Thank you, Dr.
Thank you, sir.
In a light rain, was it from your unit or some other unit? No, it doesn't matter. See, it happens, but you have to defend, right? Okay.
Yes, sir.
What you are presenting means you are managing the case. Rawat, sir.
Harshini, very well presented case. I'm very happy with the way you have presented the entire case. My only question is that when you reached to your diagnosis, what was your final impression? Whether it is a non-serious pneumonia or it is a serious pneumonia?
So non-serious pneumonia only, sir. Like at the time of presentation, sir, at the admission. So
then, why did you admit the child? You admitted the child. You have started oxygen, started on.
Sir, because.
So do you treat a non-serious pneumonia with oxygen and ceftriaxone?
So saturation it was 92%, no, sir. So we started on oxygen, sir.
No, you first tell me. You are telling it is a non-serious pneumonia, and why do you want to admit the child? Child with non-serious pneumonia can be treated at home. So as soon as you see a child with pneumonia, you have to decide basically you're going to treat at home, you're going to treat in the hospital. So you classify into two types, whether it is non-serious or serious pneumonia. So your assessment was it is a non-serious pneumonia. Now I'll ask you, what do you differentiate between serious and non-serious? What are the points in which you differentiate? Is serious from a non-serious?
Sir, serious pneumonia, if there are impending signs of respiratory failure like cyanosis and increased respiratory efforts like grunting, nasal flaring, and no, sir. Child had only saturation was the issue and mild intercostal, increased work of breathing, mild intercostal and subcostal retraction, sir.
So that those two things are more important. Like a child is hypoxic and
yes,
and is having signs of respiratory distress. Both are enough to classify the child is having serious
pneumonia. Yes, sir. Yes, sir.
So otherwise, you would have sent him home. Okay. So your child start with the child with serious pneumonia. That's why you admitted the child and you started the child on IV third generation cephalosporin.
Yes.
Archini,
okay.
Archini, it tempts me to ask a question. Suppose it has not responded to doxycycline also, what you would have done? I will tell you the answer also. When we ask question, we will tell you the answer also. That is for the benefit of others. See, that's important. Suppose it has not responded to azithromycin, doxycycline, then what you would have done?
Sir, I don't know, sir. I did not come across.
No, you should come to the next one. You should do bronchoscopy and CT first. You find out what is happening to the parenchyma, correct? So that's the flow. See, I'm just teaching you. This is Rawat sir and Sharma ji, no marks for this part of the discussion. This is beneficial for the audience. See, yes, that's sir. The point. So you will go for evaluation of the parenchyma, which is involved, basically right lower lobe. You would see what is happening there. That's point number one. Second, in terms of evaluation, other than bronchoscopy and CT, can you do something in India? I'm giving a hint to you. With an effusion, you should first rule out tuberculosis. You don't wait for 14 days and then go by RNTCP or NTEP for tuberculosis. No, there could be some hint at this stage itself tuberculosis. Yes, now, sir. Can you tell me why this is not tuberculosis from beginning itself? I will tell you 100% it will not be tuberculosis, but why? So prolonged cough, like 2 weeks cough was okay. That is at the end of 2 weeks, ma. You can't wait all the coughs to go up to 2 weeks. So you wait for another 5 days for the cough to become 2 weeks. So tuberculosis hints you should be able to get very early. That's the point. Early diagnosis, too early diagnosis. I'm asking you the first week itself.
So there was no history of contact with tuberculosis.
1. Okay.
Uh,
Fair enough. For want of time, let me tell you the answer. This is out of the competition.
Yes, sir.
Suppose in this child the effusion was more than pneumonia
And then we have to suspect
or
tuberculosis.
isolated effusion.
Yes, sir.
And how often you see sympneumonic effusions in tuberculosis? Quite rare. Did you understand?
Rare,
Either you
yes,
have
sir.
parenchyma or
Or effusion. Yes, sir.
effusion. Excellent. No, you should have come out. See, beta, we want you to come out with such things which are very, very valuable clinical pulse. Either you get an effusion or you get
Or
a
pneumonia.
and
Yes, sir.
sympneumonic is unlikely to be tuberculosis. Do you agree? I mean, I can't give you a textbook definition, but that's the behavior, how it behaves. And we
Yes,
know
sir.
that tuberculosis behaves atypical way also. Fine, fair.
Yes, sir.
I think we'll close it. These two were for the benefit of audience, not for her. Okay, continue.
Thank you, sir.
Over to Shishalam, the next contestant.
Thank you, sir. I think the next code is 3636. Always.
उस कंडीशन में 5 मिनट इज द की फैक्टर. T1 का मतलब है इतने टाइम पे दवाई स्टार्ट हो जानी चाहिए. अगर किसी
Always, your time starts now. It is 12:31. You have 10 minutes to go.
Yes.
Go ahead.
Good afternoon, everyone. I'll be presenting here of a 14-year-old male child who was brought with complaints of fever, which was high grade, intermittent type, and associated with generalized myalgia, left thigh pain. All of this was since 4 days, and hurried breathing since 1 day. The child was third in birth order, born to a non-consanguineous parentage with uneventful antenatal and birth history. Development was appropriate for age, and the child was immunized up to date according to national immunization schedule. There was no significant family or past history. Coming to the clinical examination, on examination, the child was febrile, tachypneic with chest indrawing. The remainder of his systemic examination was unremarkable. In view of severe respiratory distress and impending respiratory failure, child was intubated and connected to mechanical ventilator. The initial blood investigations sent showed leukopenia with a total count of 3,100, neutrophils being 92.3%, with an absolute neutrophil count of 2,800, lymphocytes 3.4%. With thrombocytopenia, platelet count of 1.25 lakhs, with elevated inflammatory markers. ESR was 70, procalcitonin was 300, and CRP was 193, with a deranged coagulation profile. The child was empirically started on piperacillin tazobactam. Chest X-ray done showed bilateral non-homogeneous opacities. Repeat investigations on day 2 showed worsening counts, a drop in platelet with a total count of 1,500. The blood culture sent at admission grew methicillin resistant Staph aureus. Based on the worsening of the counts and the clinical deterioration, antibiotics were escalated to meropenem and vancomycin. On day 10 of hospital stay, the child was extubated and put on BiPAP mode of ventilation. Chest X-ray done at this point showed bilateral pneumothorax with pneumatoceles seen. HRCT done at this point showed bilateral pneumothorax with multiple cavities in bilateral lungs and dense consolidations in the right middle and lower lobes and the left lower lobe. This is a CT image showing right hydropneumothorax. On day 21, child had continuous fever spikes and antibiotics were hence changed to linezolid with addition of an antifungal. On day 25, in view of reduced air entry in bilateral lung fields, the child was taken up for thoracoscopy, where pleurectomy was done and ICD was replaced. Over the next 2 weeks, child showed marginal improvement, but remained oxygen dependent and with persistent tachycardia and tachypnea. Hence, CCT done showed homogeneously enhancing lesions in the posterior basal segments of the right lower lobe, suggestive of round pneumonia, and consolidation in the anteromedial basal and posterior basal segments of the left lower lobe, with bilateral pneumothorax with a bronchopleural fistula and multiple cavitary lesions. So this is the CCT chest showing right-sided hypodense areas liquefactive necrotic tissue with multiple cavitary lesions. CEC chest image showing pseudoaneurysm. So on day 45, the child underwent right lower lobectomy to remove the necrotic tissue and the bronchopleural fistula, as the previously done pleurectomy had failed. So this is an intraoperative photo of the right lower lobectomy. This chest X-ray following the right lower lobectomy. So other investigations that were done were immunoglobulin profile, which was normal. Chronic granulomatous disease workup was done, flow cytometry, which was also normal, and HIV HbSAg done was negative. The child required prolonged PICU stay, requiring oxygen support and long course of IV antibiotics. Over the next few weeks, the child showed signs of recovery and was able to be discharged after 75 days of hospital stay. Weeks after discharge, he was readmitted with limping and was confirmed to have osteomyelitis of left femur, which was treated with surgical curettage, followed by immobilization and antibiotics. The gram staining of the intraoperatively drained serosanguinous fluid showed gram-positive cocci in clusters. So coming to the discussion, necrotizing pneumonia is a rare but severe complication of community-acquired pneumonia in the pediatric age group, which is characterized by liquefaction and cavitation of lung tissue. It complicates between 0.8 to 7% of community-acquired pneumonia. It is defined as patchy inflammation with microabscesses and decreased perfusion on computed tomography with necrotic and cavitary lesions. It is almost always complicated with parapneumonic effusion, empyema, or bronchopleural fistulae. It is characterized by necrosis, liquefaction of the lung parenchyma, which is thought to be secondary to ischemia caused by thrombosis of the intrapulmonary vessels and can culminate in pulmonary gangrene. The most common pathogens associated are Staph aureus, Streptococcus pneumoniae, and Klebsiella pneumonia. Our case developed necrotizing pneumonia with an underlying cryptic focus in the left femur due to an occult osteomyelitic process following a Staphylococcus aureus infection. Managing patients with necrotizing pneumonia is challenging because there is no firm guidelines outlining the management. The mainstay of treatment is supportive care with appropriate antibiotics. Surgical intervention may play a role when medical therapy fails. So the result of the surgery is considerably influenced by the extent of necrosis, which determines the extent of pulmonary resection. This case highlights, albeit rarely, Staph aureus necrotizing pneumonia may present in adolescents without underlying risk factors, and it should be considered in case of cavitating pneumonia. Once the diagnosis is made, source control and antibiotics are of utmost importance. Even though uncommon, it is prudent to remind ourselves that community-acquired pneumonia may be complicated by severe necrotizing pneumonia in a previously well child, like in our case, and may warrant extensive workup and aggressive treatment.
Can you stop sharing?
Yes, sir.
Yes, Dr. Subramania, please.
Sir, shall I start? Sharmaji?
Yes,
sir, you start, sir. Every time I start. So
Yeah,
let it go.
I have one question. Once you have got the sensitivity done and the organism isolated,
yes,
you don't want to go with 2 or 3 drugs. What is the fun of getting the sensitivity done? It has to be a narrow spectrum if you isolate the organism. Why
Yes.
meropenem was added?
So the reason for this was, sir, because of even after starting antibiotic, which were based on the sensitivity pattern.
Before starting antibiotic. Once you got the sensitivity pattern, you got the organism, what should have been the correct prescription?
Antibiotic which is active against methicillin resistant Staph aureus.
And you chosen that?
Yes, sir. Vancomycin was added.
Broad spectrum was added.
Sir?
Why a broad spectrum was added then?
So the reason for this was we had an organism, we wanted to target that organism, but since admission, the child had went deteriorating. So based on the clinical deterioration and the
You know the
present
reason, you know the reason for deterioration, that the child is having a resistant organism which is sensitive to certain antibiotics which you have chosen. Okay, so what was the reason for non-response to the correct antibiotic? Why the child was progressively deteriorating and required surgery?
Yes, because of nosocomial infections. Because of nosocomial infections, there was recurrent iatrogenic also. Because of recurrent, there was bilateral pneumothorax. So ICD placement was there, and there was development of bronchopleural fistula. So even hospital-acquired infections.
You think the cause of deterioration is the secondary infection?
Maybe
primary was
secondary or
controlled.
the toxic nature of the primary causative organism.
Dr. Subramania, please.
So was meropenem, so the best way overseas would be the meropenem was started by surgeon while we gave vancomycin, you know, that makes the answer very simple. These surgeons will always start meropenem, don't worry. So you can just blame it on surgeons. You should know how to blame. Even no, I'm not for competition. Even in rounds, you tell thoracic surgeon started while we started vancomycin. And this is in a lighter vein for Sharmaji's question. Okay, let me tell you. This was where was the origin for this MRSA?
So at first, this was we did not know, sir. It was quite inconspicuous.
Now,
So
what do you think?
now it was the focus was actually the osteomyelitis of the
for the osteomyelitis, from where it came?
Left femur, sir.
No, it cannot originate in left femur. From where it came? That is my question.
So on detailed, the second time when the child came, sir, we asked about pyoderma, sir.
Okay.
So there was a vague history, not reliable, but vague history about skin condition in the child.
That is one. Okay, one is skin. Second, any other, what other questions you will ask? See, ultimately, you can't treat the targets of MRSA. You should treat the source of MRSA.
Yes.
I think that's the point. That's the message for the public, but anyway, for you, it's a question.
So the way the child presented, sir, the acute nature of and the acute worsening, the way the child presented. So based on that.
No, I will give a hint to you. An adolescent who comes with MRSA, what are the possibilities?
So the first thing we were thinking of was immunodeficiency, sir, because it was
no, adolescent. Behaviors of adolescents. You know, nose picking.
MRSA, yes, sir. No.
So the nose can be the source. I'm sorry, it can be the source of staph, and by chance he may get. No, I will tell you the answer, but I may be incorrect, but may not be related to this. Can it be somebody with intravenous drug abuse?
Yes, sir. Intravenous drug abuse. Yes, sir. Yes, sir.
That could have, if you would have told that answer, I would have given you full marks. You know, intravenous drug abuse can be a source for, staph.
But, yeah, in a 14-year-old child.
And they won't tell you, no, I'm using the drug. Nobody will tell, isn't it?
There was nothing indicating.
No, nobody will be there. Now, do you think the femur and the lung lesions are the targets of some other source, or is it that the femur has led to the lung?
So the way the child presented, sir, with the left thigh pain, that was one of the concerning complaints of the mother and the child. So I would incline towards the femur being the focus and the source for
I would just argue that it was seeded into femur and the lung, and the femur started first and the lung took some time. Is it possible?
Yes, sir. That
one after another, giving a false picture of a femur leading to the lung.
That is possible because the presenting, there was no cough or there was no.
No, the cough won't be there when it is bacteremic spread.
Yes, sir.
It didn't start from the airway. Did you understand?
Yes, sir.
See, that's the teaching I'm doing for you. This is not a seeded staph from the inhalation route.
Yes, sir.
This is a staph that is seeded from hematogenous route.
Yes.
And it has gone to the femur and it has gone to the lungs. Now, are you now clearly understanding the pathogenesis?
Yes.
Now the question of relevance of intravenous drug abuse, skin, community acquired, contact with ICU, your hospital, your bugger, your intensivist, your surgeon, your OTMRSA, all of them should come. Did you understand?
Yes.
So that's the flow. I'm sorry if I'm got into a teaching mode rather than asking mode. Over to Rawat sir.
Yes, always. Two comments and one question. I was not clear whether you are presenting a case or you are giving a case report which you are want to publish in a journal, because case presentation, when you are doing a case presentation, you have to be more detailed in your history and you are trying to tell us the information. You spend more time on the entire building of the case after got admitted and all those things. So whenever you are going to present a case, an examiner is basically interested that how you have worked up the case, not that how you have managed the case in hospital. That is the job of an intensivist. So as a PG, your primary aim is to present the case in which the examiner should be able to understand that how did you come to this particular diagnosis. So I think you spend very less time in the history, which probably is a negative point for your presentation. My question to you is that when you admitted the child, your first treatment you gave was IV piperacillin tazobactam. Why did you choose piptaz? What is the drug of choice when you admit a child with serious pneumonia?
So the drug of choice is amoxicillin, sir. IV amoxicillin. But
no, it is not. What are the guidelines of treating a child with serious pneumonia when you admit in the hospital? What is the drug of choice? It is not amoxicillin.
Severe pneumonia.
Okay, I'll tell you. The drug of choice is IV third generation cephalosporin.
Ceftriaxone, pa? Why do you get worried?
Ceftriaxone. Treat with ceftriaxone. You never use. That is used only in cases of hospital-acquired pneumonia, where you suspect hospital-acquired bugs who are resistant to ESBL. So whenever you treat a community-acquired pneumonia, serious child admitted in hospital, the drug of choice is ceftriaxone. It is not piperacillin. This should be very clear.
And secondly, in an adolescent, IV amoxicillin doesn't offer any advantage over oral amoxicillin. I'll tell you, for example, beta, you can give 90 milligram per kg of amoxicillin orally, which works better than your 40 milligram per kg of amoxiclav that you push. Did you understand my point? Are you getting the message? So don't worry about it, isn't it? Orally can be equally good effective, provided you give good doses. Suppose you are contemplating some kind of serious situations, then you can go on higher doses of amoxicillin. But as the drug of choice would be cephalosporin.
So my
time up. Yeah, we got the point.
Advice to all the PGs would be that you be clear in your basics. Don't go on high-flown things. They are not important at this stage. You should know clearly what is serious, what is non-serious pneumonia. You build up the case for proper history, and you have to know the proper treatment, serious versus non-serious. Okay.
Okay. Can we go to the next case?
Yes, sir. We have exceeded more than 45 minutes. 45 minutes exceeded, sir. So the next case is 37. Code 37.
Yes. Good afternoon, sir. Sir, is my screen visible, sir?
Yes, visible and audible.
Yeah, it is visible. Your time starts now, 12:50. Okay.
Good afternoon, everyone. Today, I am presenting a unusual case with a history. 15 years old girl came with the chief complaints of fever 7 days duration, fast breathing, lethargy, vomiting 3 days duration, unresponsive, worsening lethargy 1 day duration. She was admitted in a referral hospital on day 4 of illness. She has hypotensive shock, intubated, and started on inotropes. And antibiotics, piptaz and clindamycin were given. She was connected to mechanical ventilator, developed right side pneumothorax. In view of refractory hypoxia, referred to our center. Management, at the time of admission, her vitals were, she was febrile with 100.9 degree Fahrenheit, heart rate is 122 per minute, and saturations were 85% with bag and tube ventilation with 100% O2, and BP was 80 by 50, 64, mean BP was 64 millimeter mercury, Respiratory rate is 50 per minute with ICD in situ in right lung. On examination, she was paler and CVS is normal. S1 and S2 hurt. Respiratory system decreased air entry on right middle and inframammary area compared to the left. CNS, she was lethargic, responding to deep pain. Pupils bilaterally reacting to light. Her GCS was 11/15. She was immediately connected to the ventilator of conventional mode, PR with with pressure control mode, and ABG was done with pH 7.29, PCO2 51.3, PO2 44.3, bicarbonate 29, base excess to -2.2. The interpretation with ABG was respiratory acidosis with hypoxia. Her PO2 with FiO2 ratio is 44 and oxygenation index was 44. X-ray was done, which shows interpretation of bilateral ground glass opacities in both middle and lower zones, suggestive of bilateral consolidation. Bronchopneumonia with ICD in situ was the interpretation. With all these things, with the high OA more than 44 and P/F ratio more than 44, based on the Berlin definition of ARDS, within 1 week of a known clinical insert and bilateral opacities on X-ray, and oxygenation index P/F ratio less than 100 with a PEEP of more than 5 centimeters of H2O, she comes under severe ARDS and was indicated for ECMO, but we went on for rescue measures. Her ventilation management was in view of severe hypoxemia and high OA. She was connected to the HFOV, high frequency oscillatory ventilation, with the settings of MAP 20, FiO to 100%, delta P of 35. Even after 1 hour, the saturations were 66%, and we initially increased the MAP. Her investigations were HB 7.8 on at that time of admission. WBC was 28,400, which was a bit high. Platelets was 1.9 lakhs, and CRP is so high, 227, and SGPT 27. Blood culture we sent, it is awaited. IgM strep type we sent, and respiratory panel were awaited, sir. Based on these high counts, and high raised CRP with bilateral consultation, empirical antibiotics and low dose steroids were added, sir, initially. We have two differential, the bacterial or viral. Bacterial we added with the meropenem, linezolid, and doxycycline, azithromycin. And viral oral oseltamivir was OG oseltamivir was added, sir. The child was ventilated with increasing MAP to 25 and saturations improved to 88%. In view of high oxygenation index, and the inhaled nitric oxide was started at 20 parts per minute, and saturations improved to 90% within 46 hours. Hence, ECMO option was called off in this child. We started on the prone ventilation. The importance was the child was sedated and paralyzed. Prone ventilation for 48 hours to avoid the ventilation perfusion mismatch and effective lungs oxygenation of the lungs. There is the importance of Prosiva, prone ventilation in severe acute respiratory distress syndrome. There is a trial in which they compared RCT in patients with severe ARDS. Early application of prolonged prone positioning sessions significantly decreased 28-day and 90-day mortality. Slowly, FiO2 was weaned off to 80% and MAP to 25, and the ABG shows improvement in the oxygenation. With earlier PO2 was 49 and it was increased to 56, and OA was decreasing to 35.7, and P/F ratio is increasing. Prone ventilation continued and child was sedated with the fentanyl infusion. In view of hypotension, child was started on inotropes and tapered as BP stabilized. In view of current pandemic, the COVID-19 was RT-PCR for COVID-19 was sent, which was negative. As most common cause of ARDS in children of above age group is viral pneumonia. CAP community acquired pneumonia panel was sent, showed negative for common viral and bacterial infection causing pneumonia. In view of suspecting a strep type was causing pneumonia based on the RGA, that is Rathi-Goodman-Hagai score more than 14, complicating into ARDS. IgM for strep type was sent. As blood cultures were sterile, after 48 hours, antibiotics were de-escalated to avoid the resistance. Meropenem to the piptas, as earlier piptas were started in the referral hospital, and linezolid was stopped. Azithromycin and doxycycline continued. Oseltamivir was stopped. Investigations on later was 16 done. There is a bit fall in HP. WBC has been improved. Platelets were stable 1.5 lakhs, and CRP is bit decreasing 164. On day 5 of admission, the HB on 16th day we have given one episode of transfusion, and the HB was improved, and WBC count is decreasing. CRP was bit fall when compared to the time of admission. IgM scrub typhus was positive for this child. Slowly, the inhaled nitric oxide was tapered and based on serial ABGs and oxygen index. After 3 days of HFO ventilation, child was brought to conventional mode of ventilation, that is PRVC. After 48 hours on conventional mode of ventilation, child was extubated to non-invasive mode, that is CPAP. Based on the P by F ratio and oxygenation index and ABGs, child was weaned to low flow and ICD was clamped as distress settled and removed after no flow in the column and improved air entry on auscultation. Child was started on chest physiotherapy with regular spirometry exercises for improvement in the lung expansion. Child was discharged in 12 days. This is how we managed a severe ARDS case with unusual presentation of strep typhus pneumonia with HFO-INO, that is lung protective ventilation, and prone ventilation with a low dose steroids and IV doxycycline. Post-extubation X-ray showed decrease the opacities and improving more on the left side. Discussion a bit part. Scrub typhus. Scrub typhus is an important cause of acute febrile illness in South and East Asia and the Pacific regions. This causative agent is Orantius susugamushi. It can affect the lungs from mild illness like pneumonitis to severe illness like ARDS. This is a Susugamushi triangle where globally 1 billion people are at risk and 1 million cases are occurring annually. Apart from all the world, India is endemic for forest clearings and river banks, grassy region, mite islands. So we have to keep in mind that scrub typhus is also one of the differential diagnoses causing the pneumonia. A bit about ARDS, it's an acute lung injury that can be triggered by heterogeneous set of pulmonary, a direct injury, and extrapulmonary indirect lung injury. Taking into the pediatric ARDS criteria based on PALIC guidelines, it should be acute onset within 7 days of clinical insult, chest imaging findings of new infiltrates consistent with new parenchymal disease, edema not fully explained by fluid overload or cardiac failure. What is RGA scoring? Rati Goodman-Nagai scoring was used in the diagnosis of this scrub typhus. It includes the following components of clinical features and laboratory, which is rural pets, and we have to, based on this criteria, if it is more than 14, we have to send for this IgM for scrub typhus or PCR. We have sent this IgM for scrub typhus, which comes to be positive, and RGS score of more than or equal to 14 showed sensitivity of 93.8% in those with both IgM ELIS and PCR positive for strep typhus. Conclusion: even though Western books say viral illness is most common for cause for ARDS, in Indian setting, strep typhus should also be considered. We should rationally use antibiotics and de-escalate as quickly as possible. Thank you.
Well done. You have finished before time.
Yes,
Sir, over to the judges. Sharma sir, Rawat sir, and Subramanian sir.
Rawat sir.
No questions.
Rawat sir, please.
No questions, please.
It exactly seems what Dr. Rawat has said. It looks like a case reporting rather than case presentation, because what you have treated is the reports, not the case. You have not made any effort to make us to think what is this case. There was nothing in the history, nothing which led to a tentative diagnosis. It was all messed up with the reports of ABG and all those things, and nothing basically was conveyed in this case presentation. Dr. Subramania, please.
Subramanian sir.
Is there any clue in the history or the initial investigation where you could think of scrub typhus?
With the history of fever more than
indicative of moods. That is the usual presentation. Unexplained fever with multi-organ dysfunction. There was nothing like that. So you covered almost everything. COVID and influenza and any bacteria, piperacillin and everything.
Yes.
Thank you.
Subramanian sir. Oh, okay. Okay, fine.
No, not there. Can we take the next case?
Yeah, we'll go to the next case.
We can go.
Board number 41, Shruti Prajna.
Am I audible, sir?
Yeah, Shruti, you can start slideshow.
Am I audible?
Yeah, you are audible.
Yes, sir.
Start the slideshow. And your
Is
time
it
starts
visible, sir?
now. Yeah, it is there. 1 o'clock, you have 10 minutes to go.
Yes. A very good afternoon to revered judges, seniors, and dear colleagues. My serial number is 41. So we are dealing with a 2-month-old female child, a resident of Viluppuram district in Tamil Nadu. The informant is mother, who is a well-educated woman, and hence the history is reliable. So the child was brought to us with a history of cough coryza for 20 days, fast breathing for 20 days, progressive fast breathing for 20 days, and fever for 4 days. So this was a term child with spontaneous vaginal delivery, weighing 2.9 kgs at birth, appropriate for gestational age, and had a smooth perinatal transition. The mother gives a history of cough and coryza for 20 days, paroxysmal in nature, present in bouts, predominantly dry in nature, and associated with post-stressive vomiting, however, with no diurnal variation. She also gives a history of progressive respiratory distress, noted in the form of fast breathing and chest retractions since 20 days. There's a history of fever for 4 days, as told by the mother based on local touch, low grade in nature, intermittent with no diurnal variation, and subsiding on oral medication. There's on probing, there was history of bad child rearing practices, intermittent oral instillation and blowing since 7 days of life. This is a predominant child rearing practice localized to this part of the country and is still in process. Another concern by the mother was poor weight gain since birth, and there's no history or suggestive of aspiration in the form of feeding difficulty, choking episodes of frothing. There was no history suggestive of congenital heart disease in the form of sucrose suck cycle, brow sweating, dependent edema, bluish discoloration of skin. There were no history of bouts of incessant cry or ear discharge, no history of persistent vomiting or loose stools, no history of frequent bulky greasy stools or bloated abdomen by the mother. There's no history of sudden onset choking episode or no history suggestive of foreign body aspiration. No history of poor feeding or lethargy, and the sensorium, according to mother, has always been normal. Moving on to the past history, the child has had 2 significant hospitalizations. The first admission was at 15 days of life. This was predominantly for fever for 4 days and managed as late onset neonatal sepsis with IV antibiotics for 5 days, following which the child was at home feeding well for the next 30 days. The second admission was at 45 days of life. This time the concern was cough coryza and respiratory distress for 2 days, associated with fever, managed as bronchopneumonia, both diagnosed clinico-radiologically, multiple IV antibiotics given appropriately for 15 days, and was discharged against medical advice and referred to our hospital for further management. This was a second-born child to non-consanguineously married parents. There's no chronic respiratory illness or bronchial asthma or allergy running in the family. There's no history of contact with tuberculosis. On probing, parents are retronegative. No history of close contact with a habitual smoker. On eliciting birth history, the child was conceived naturally at 23 years of age, booked and institutionally delivered. The birth details have already elicited in the beginning. The antenatal period was
अभी सब
otherwise
इकट्ठे खाएंगे
uneventful. No history suggestive of
आधा घंटा
intrauterine
लग जाएगा
infection in
थोड़ा
the
लेट
form
हो
of
गया आधा घंटा 1 बजे
or
तक था
rash.
थोड़ा लेट हो गया
There's no history of chronic drug intake. Antenatal scans were not suggestive of any gross congenital anomalies. The child's perinatal transition was otherwise smooth. She was initiated on breastfeeds 1 hour following delivery and has been exclusively breastfed with no prelactal feeds. She passed meconium on day 1 of life, and there's no history of prolonged neonatal jaundice or delayed umbilical cord separation. The child otherwise is developmentally normal according to mother and has been immunized till 10 weeks of life as per national immunization schedule. She is breastfed on demand, and there are no faulty feeding practices elicited. She belongs to a family of 4 members with an annual per capita income of monthly per capita income of 5,000 rupees. They belong to upper lower socioeconomic status according to modified Kuppuswamy scale. On eliciting, I could not find any history suggestive of overcrowding or indoor air pollution. On examination, the child was examined in supine position while in mother's lap. She was, however, irritable but consolable. She appeared less interested in surroundings and generally appeared emaciated. On eliciting the vitals, she was afebrile. Her pulse rate was 144 per minute, regular in rhythm and normal volume and character. Her respiratory rate was 62 cycles per minute, regular with thoraco-abdominal type and with subcostal and intercostal recession suggestive of tachypnea with increased work of breathing. Capillary refill time was, however, normal. Non-invasive BP was within 50th to 90th centile, measured in the right upper limb as adjusted with the normal children as per weight and height. Saturation at room air was 93%, which increased to 99% with 40% FiO2. The hydration of the child was otherwise fair. On head-to-toe examination, she had mild pallor. However, there was no icterus, clubbing, cyanosis, significant lymphadenopathy, or dependent edema. There were no features of dysmorphism. Skull was normal. Anterior fontanelle could admit 2 fingers and was in level. Hair appeared sparse, hypopigmented, and lustreless. Oral examination showed no evidence of discharge, and tympanic membranes were intact bilaterally. Ears were normal, and we could not find any evidence of flictin or allergic rhinitis. Oral cavity showed no evidence of cleft. Hygiene was otherwise fair. BCG scar was present. No evidence of skin infection. No features of vitamin D deficiency. No features of vitamin deficiency noted. Genitalia was of a normal female phenotype. She weighed 3 kgs with a Z score of minus 2.89 Z, suggestive of undernutrition. Her length was 53 centimeters with a Z score of minus 2.91 Z, suggestive of stunting, and her weight for length was 3, which was minus 3.38 Z, and satisfied the criteria of severe acute malnutrition according to WHO and IAP. Her head circumference was otherwise normal. So, based on the history and the child predominantly presented with cough, coryza, and fever, I would like to do a focused examination of the respiratory system to begin with. On inspection, trachea appeared in midline. Apical impulse was seen in the 5th intercostal space lateral to the left midclavicular line. There were no chest wall deformities. Chest movements were symmetrical, perhaps a little reduced than normal. Very difficult to comment when it's a young infant. There were no crowding of ribs, and skin over the chest appeared normal. Inspectory findings were confirmed on palpation, and trachea appeared mildly deviated to the left side. On percussion, dull note on percussion on right, over the right interscapular and infrascapular region was noted. All other lung fields appeared, however, resonant. On auscultation, no audible breath sounds were present. No audible breath sounds were there. Breath sounds appeared reduced in the right inter and infrascapular region, and bronchial breath sounds were audible in the right interscapular and infrascapular area, and diffuse bilateral coarse crepitations were heard. On examination of other systems, cardiac system, precordium appeared normal. Apex beat was localized to the 5th intercostal space, just lateral to the left midclavicular line. S1 and S2 were heard, no murmurs present. Abdominal system, abdomen appeared soft, umbilicus central and inverted. Liver was just palpable below the right costal margin with a span of 6 centimeters, soft and
2 minutes left for you.
smooth
2
round
minutes.
borders. Yes, sir. Spleen not palpable, no free fluid. The nervous system was otherwise no abnormality. On examination of nervous system, there were no abnormalities detected. So with the case, we were thinking in terms of pneumonia, since the child presented predominantly with fever, cough and cold, and the child had been appropriately treated with IV antibiotics before. So perhaps a child who was going towards the course of a persistent pneumonia, the child also had failure to thrive, and there was a significant history of oil installation. On investigation, complete hemogram showed persistent leukocytosis with neutrophilic predominance and microcytic hypochromic anemia. The renal and liver function tests were otherwise normal. The blood gas showed mild respiratory alkalosis. So on radiological assessment, chest X-ray posterior film showed persistent homogeneous opacity, predominantly involving the right middle zone and upper zone, taken on day 1. Here you can also see that the thymus was appeared hyperplastic or perhaps absent. So we did have a consideration of primary immunodeficiency. We also noted a healing fracture involving the right 7th rib. The HRCT of thorax revealed areas of consolidation involving the right upper and lower zones with no significant lymphadenopathy. Similar consolidatory changes were also seen in the left upper lobe. There was evidence of bronchitactic changes involving the right upper lobe and middle zone as well. And our suspicion of the 7th rib fracture was confirmed on HRCT. So considering primary workup for by this time the child had met criteria of persistent pneumonia. So we went ahead with the detailed workup for persistent pneumonia. Blood cultures were sterile. 2D echogram did not suggest of any significant abnormality. Immunoglobulin profile was normal. Lymphocyte subset assay and evaluation of chronic granulomatous disease was negative. Even leukocyte addition defect, which we suspected because of leukocytosis, was normal. Milk scans showed no evidence of GER. Workup for tuberculosis was normal. Non-contributory. Bronchoscopy, because of persistent respiratory distress, preoperative anesthetic witness was denied. We also worked up for cystic fibrosis because the child had chronic pneumonia with a failure to thrive. However, it was non-contributory by two conclusive sweat chloride tests and CFTR gene mutations for 4 common mutations.
Time up.
However, finally, on aspiration of the lung aspirate through fine needle aspiration, we yielded an organism called the Mycobacterium goodi. So our final clinical diagnosis at the end of treatment was persistent pneumonia by Mycobacterium goodi, and this organism has been known to be associated. I mean, there's a case report with lipoid pneumonia, and we all know there is a chance of association of non-typical mycobacterium with cystic fibrosis. This child also presented with severe acute malnutrition and nutritional anemia. So I'll just briefly touch upon the salient features of management. When the child presented to us, she was sick. She required NIV support, which was de-escalated to high frequency, high flow humidified nasal cannula, delivering oxygen, and subsequently tapered to nasal prongs requiring minimal oxygen. Intravenous antibiotics to begin with, we started on meropenem and vancomycin, which was begun in the hospital that referred the child to us. Considering atypical organism involvement, we started the child on azithromycin. However, by this time, we received the Mycobacterium goodi in lung aspirate, and we modified our antibiotics to meropenem and gave it for 14 more days. The nutritional rehabilitation was taken care of. Air clearance therapy in the form of hypertonic saline nebulizations and chest therapy, gentle chest therapy was encouraged. Supportive care in the form of blood transfusion was also given. So what we learned was exogenous lipoid pneumonia can still contribute to pneumonia and it should be highly suspected given a positive history. And cystic fibrosis must be strongly suspected in the setting of a persistent pneumonia with failure to thrive. A wide range of atypical microorganisms are frequently recovered from the airway of patients with cystic fibrosis, and non-tuberculous mycobacterial species can be one out of these many. And in the setting where bronchoscopy is inaccessible or contraindicated, a careful fine needle lung aspiration in controlled environment can help us in yielding the microbiological specimen and treat the case, which is often difficult. So
I think we should wrap up now.
Yes,
it is
sir.
already, you're overshooting the time.
Yes, sir.
2 minutes. More than 2 minutes.
Yes. Thank you, sir.
Hello. Yeah.
Sir, over to the judges. Sharma sir, Rawat sir, and Subramaniam sir.
Rawat sir, please.
Okay.
Dr. Gaba, please mute yourself.
Yes, Dr.
Gaba.
Kar, now, although what I could understand for the entire case presentation that you are two important dynamics in your mind.
Yes, sir.
Fibrosis and the pneumonia, but your presentation was so huge and it contains so amount of irrelevant detail that your main thing it got lost in the entire maze of things which are non-relevant. So whenever you're going to present a case, you have to ask everything, but present only that thing which is relevant. Because if you present lot of irrelevant things, your main relevant things they get lost, and the judges they can understand what you want to say. So first you have to be relevant and be specific to what you're going to present.
Yes.
Now my question to you is that how do you confirm or rule out diagnosis of lipoid pneumonia? Because you have repeatedly told that there is history of oil infiltration in the nose, X-ray showing persistent pneumonia. So what did you do to confirm or rule out lipoid pneumonia in this child?
So actually, we did the bronchoalveolar lavage. The gastric aspirate lavage that did not yield any lipid-laden macrophages. Also, the classical radiographical image on CT suggestive of ground glass appearance was not there. And the main lacking on our part was we could not go ahead with bronchoscopy given that the fitness was denied. So if that was there and if we could recover lipid-laden macrophages, that would have clinched the diagnosis for us, sir.
Now, and then second, since you could grow NTM in this child, so could it still be cystic fibrosis? Because although you rule out 4 mutations in the child, but could it be still a rare mutation causing cystic fibrosis?
Definitely, sir. That's what we still could not rule out cystic fibrosis in the child. And given that the mutation analysis which we do is only for the 4 common mutations, it could still be a child with cystic fibrosis, given that the child has failure to thrive and perhaps persistent pneumonia in the setting of non-tuberculous mycobacterium isolated. There is evidence of chronic cough. Perhaps that is suggestive of a rib fracture too.
Okay, thank you.
So your final diagnosis is still cystic fibrosis with NTM.
My final diagnosis would be persistent pneumonia, sir. I would still like to keep to
persistent pneumonia.
Sir?
What is the definition of persistent pneumonia?
It is fitting the definition of persistent pneumonia. The child presented with features of persistent pneumonia, appropriately treated with IV antibiotics, more than 10 days, sir. Given a period of 30 clinical plus radiological evidence of pneumonia, appropriately treated with antibiotics for a minimum of 10 days. Beyond 30 days is termed as persistent pneumonia, and the child fits the definition, sir.
So your child fits into that?
Yes, sir.
Okay, you said the child had history of cough and coryza.
Yes, sir.
So how this NTM can lead to coryza? Upper respiratory symptoms? Why not PCD? Why not primary ciliary dyskinesia given a consideration? If the upper airway symptoms are there.
But there's no setting of immunodeficiency as such, except for that the child was.
I'm saying primary ciliary dyskinesia.
Shruti Pranja, can I come to your help? You tell Sharmaji sir that there was no bilateral ear discharge.
Yes, sir.
See, he's smiling now. He wants that answer from you. So you wanted to clinically exclude PCD by some more features of mucociliary handicap.
Yes, sir.
No?
Yes, sir.
Yeah. See, Sharmaji sir, can I ask a couple of questions? No, there was absence of thymic shadow.
Yes,
and
sir.
There was some fractures. Can it be DiGeorge syndrome?
But there's no evidence of hypocalcemia, sir.
No, was the calcium levels normal?
Yes, sir.
Yes.
Calcium. Yeah, it was 11.2 on 2 different.
And what about 2D echo?
2D echo was suggestive of only small atrial septal defect, no conotruncal anomalies.
Your CT can confirm thymic aplasia? What was the CT report of thymus?
CT report of thymus was suggestive of presence of thymus was normal, sir.
Normal means over. See, that's fine.
Okay, but how you have ruled out the surfactant protein metabolic disorders in this child?
We could not rule out, sir. That is why my differentials will
That
still
is
be
still a
50.
strong possibility in this child.
Yes, sir. Exogenous lipoid pneumonia is still a possibility, and there are case reports with the Mycobacterium goodie presenting with children with lipoid pneumonia. So we cannot rule that out until we go ahead with the bronchoscopy and bronchoalveolar lavage, conclusively at least.
How many mutations we check in India?
4 common mutations are checked, sir.
How many mutations are there in cystic fibrosis?
Innumerable, sir.
Approximately. Available in the market or available for our bird's eye view for the benefit of others. Can you tell us?
Not.
Around 1,800 plus.
Okay, sir.
So, I mean, you can go n number of them, but anyway, fair enough. Four common. Can you tell me what is that? What is the most common gene?
So delta F508 deletion, sir.
Fine.
Belonging to class 6.
Thank you, ma.
Thank you.
For want of, can you stop sharing the screen?
Yes.
So,
for us to know how many are left?
The 2 are left, sir.
Okay. See, those people, I think, who had some issues with presentation need not get discouraged. It is that they were with the wrong device or with the wrong plan. Let them start. No problem. We have no issues, right?
Okay. So I would call upon
and Dr. Abhijit and one more doctor.
Yeah, this is the
who is present.
Participant code 20.
Tell me the code now.
20.
Yeah.
20.
Please go ahead.
Sir, is my screen visible?
Yeah, you can.
No, Sandeepan, please make sure that you are on video.
Yes, sir. I have on. I have made the video on.
You are not visible to us.
We can't see.
We can't see you. We can see the slide.
Yeah. Am I visible, sir?
Now you are visible.
Now you are visible.
Okay. Thank you, sir.
You start, Sandeepan.
Sorry, sir, for the delay.
Sandeepan, you should be seeing your expressions and confidence. Otherwise, that will minus 2 marks.
Yeah.
Yes,
122.
You need not show, but we will consider that as a point. So you want to see the confidence of the student and the way you present and what are your points and emphasizing. You should be seen in a presentation. If you have technical difficulties, then we will again allow Abhijit and then come back to you.
No, sir. I think I am good to go, sir.
But Rawat sir, are you seeing him?
His video is not shown.
He is not seen. He is not seen.
My video is not.
Slides are seen. Slides are there.
And my video.
Now you are there.
Yeah, we can see him now. Yeah.
Okay.
Sandeepan, you can start now at 123 for 10 minutes, right?
Okay, sir.
Go ahead.
My participation code is 20 and my case is the bleeding lung. So my patient, 6-year, 5-month-old male child, Muslim in religion, from Murshidabad, West Bengal, without any consanguinity, informant being mother and reliability being good, presented to me with fever for last 20 days and shortness of breathing for last 14 days. Now, history of present illness, the child presented in our ER. The fever was gradual in onset, progressive in nature, moderate. It started 20 days back, but it accelerated 10 days back, and it got subsided with antipyretic medication, came back after 6 to 8 hours. The child remained toxic looking in between the episodes. And shortness of breathing started 6 days back, which was gradually in onset. Initially, it started 14 days back, but after taking some medication from the local doctor, it gets subsided. But the last episode started for 6 days back, which was gradual, progressive, associated with expectorant cough and occasional chest pain. It worsened in last 2 days. There was no history of nighttime worsening of the distress or in lying down position. Relevant negative history was there was no history of trauma or foreign body aspiration, no history of significant weight loss or swelling, rash or cyanosis, dysuria or air discharge or earache wasn't there. Now, there was a significant past history. The child was admitted in local hospital with severe paleness and was diagnosed with iron deficiency anemia 5 years back. He had to transfuse 2 units of PRBC then. And then he was started with tablet iron. 6 months later, when he was on tablet iron, he had to be admitted, and he was given 1 unit of PRBC, and he was referred to hematology department for further evaluation of anemia. At that point time, he had also had 2 episodes of hematemesis, for which he was given PPI only. After continuing tablet iron for 2 years, intramuscular injection of NC curve was prescribed, suspecting iron refractory iron deficiency anemia, that is IRID, from the Department of Hematology only. Intramuscular NC curve was given for 1 year every month. At that time, workup of IRIDA was done. At that time, serum ferritin was in lower borderline level. Bone marrow biopsy showed normocellular marrow with dyserythropoiesis. Genetic mutation study of TMPSS6 were not available. Then oral tablet was started and it was withdrawn 1 year back. Total, so in this time frame, total 3 times blood transfusion were required, and last transfusion was required 2 years back. Now, the birth history was normal. In family history, his grandmother died of colon cancer. No significant history of any recurrent blood transfusion in any of his siblings or other family members. Immunization.
Sorry to interrupt you.
Sorry.
Your video is not seen because it becomes an issue that your case somebody is presenting. We cannot identify. So I think your video should be on.
No, it's okay. Let us continue, sir. Srishalam. Okay. Sandeep, you continue, no problem.
Okay.
Okay. Developmental history, it is within normal limit. Now, clinical examination, general condition, conscious, alert, cooperative, pallor plus. That is moderate pallor was there. No icterus, clubbing, edema or cyanosis or generalized lymphadenopathy. Vitals were, in vitals, heart rate was 82. The temperature was 101 degree Fahrenheit. Respiratory rate, the child was tachypneic, 38 per minute, and SpO2 was 95% with moist oxygen inhalation at the rate 6 liter per minute. And in anthropometric measurement, he was his weight was between less than 3rd percentile, height was between 3rd and 10th percentile, BMI was less than 3rd percentile. So the child was both shunted and underweight. Now, systemic examination, after considering the history, we decided to go for the respiratory system examination. In inspection, the child was tachypneic, suprasternal and subcostal retraction was there, chest wall retraction were present. In palpation, trachea was in midline, normal position of cardiac apex was there, auscultation, fine crepitation was present bilaterally, more in the apical region. Other systems were within normal limit, like hematological system, hematopoietic system, cardiovascular system, musculoskeletal, and CNS. In laboratory examination, hemoglobin was 8.8 initially. Total count was high, as much as 23,800. Neutrophilic leukocytosis was there. ESR was 78. Now, other baseline investigation was within normal limit, both renal function and liver function test. CBNAT MAN2 was normal. Other sources of other causes of fever like dengue, scrub, MP, MPDA were ruled out. Serology was normal and urine REMU was within normal limit. So initially we diagnosed pneumonia. It's a simple case of pneumonia with iron deficiency anemia, suspected IRIDA. But this was the X-ray we found at the time of admission, and it was showing bilateral interstitial ILD type of pattern. So the child is having pneumonia with ILD type of pattern, query interstitial pneumonia. So for further evaluation, we ordered for CECT thorax. He was started on IV antibiotic, broad spectrum antibiotic ceftriaxone with azithromycin, keeping atypical organisms in mind, along with moist oxygen and nebulization. And further workup of anemia was done. His iron profile showed clearly iron deficiency anemia, though the ferritin level was very high, 835.9. So we kept it in mind that he was having infection. That's why maybe the ferritin level was high. Corrected reticulocyte count was normal. Other investigations like HPLC was normal, DCT, stool occult blood test was negative. CBCPS showed microcytic, microscopic, microcytic, microchromic and RBCs without any atypical cell. So till now, the case summary, 6-year-old boy presented with history of fever for 20 days with gradually progressive respiratory distress for 14 days, associated with expectorant cough and occasional chest pain. He was diagnosed with iron deficiency anemia 5 years back, for which he received treatment in form of oral and parenteral iron supplementation along with blood transfusion. On admission, the child was febrile, moderately pale, tachypneic with moderate chest wall, subcostal retraction and saturation 95% with 6 liter per minute oxygen. Anthropometrically, he was both wasted and stunted. Fine crepitation was present bilaterally on auscultation. He had mild anemia, neutrophilic leukocytosis, elevated ESR. Iron profile was suggestive of iron deficiency anemia with elevated ferritin. Other causes of fever were ruled out. TB, hematological malignancy, GI blood loss were ruled out. Chest X-ray shows bilateral pneumonia with ILD pattern. Now we ordered for CECT. CECT shows
You have 2 minutes left, Sandeepan.
ground glass appearance, and there was also thickening of the septum. So ground glass opacity with intralobular septum thickening in both lungs was there, and it was suggestive of interstitial pneumonia. So we are having iron deficiency anemia with interstitial pneumonia in an age of 6-year-old child. So it's very uncommon in such a small child, interstitial pneumonia. So we thought, can a single disease can present with this type of spectrum? So we went for bronchoalveolar lavage that showed predominantly neutrophil. It also had pulse stain positive and also more than 30% hemosiderin-laden macrophage. So suggestive of diffused alveolar hemorrhage. Now there can be a multiple causes of diffused alveolar hemorrhage. And to rule out that, we ordered for a bunch of investigations like ANA with ANA profile, ANCA, APLA, echocardiogram was done. We also had LFT and RFT normal. So if we see iron deficiency anemia, then and it was actually refractory iron deficiency anemia, then interstitial pneumonia with ILD pattern, hemosiderin-laden macrophage in sputum, and also other causes of diffused alveolar hemorrhage were ruled out. We can come in the diagnosis of idiopathic pulmonary hemosiderosis. So the boy was discharged after 14 days of antibiotic and was discharged out with oral steroid. And the repeat chest X-ray showed clearing of the lung field. So the final diagnosis was idiopathic pulmonary hemosiderosis complicated by pneumonia. Follow-up, the patient came in follow-up after 2 months with increased hemoglobin without any iron supplementation. So he did not, it is very uncommon to stamp a pulmonary hemosiderosis without any history of hemoptysis, but he had history of hematemesis. So maybe in children, hematemesis can be confused with this hemoptysis. In this case, ILD pattern of pneumonia with iron deficiency anemia gave a hint of lung cause of anemia. And iron deficiency anemia can be a presentation of diffused alveolar hemorrhage, and idiopathic pulmonary hemosiderosis is a diagnosis of exclusion. This was my presentation. Thank you.
It was done on time. I think Subramanian
stop-
sir and the judges can take up the
Can you
case.
stop sharing the screen? Now,
Yes.
Sandeepan, it is a straightforward diagnosis of idiopathic hemosiderosis. Don't you think so?
Sir, actually, when the
Why you have
child
to go
first,
around and lastly do ball for hemosiderin?
because it was worked up so much by the hematology department, so we didn't thought of that. We just we thought it, first of all, it was we thought it was a straight case of pneumonia, and they may be a atypical organism due to the interstitial pattern. But then and
Fair
he
enough.
also didn't have
I got the
any
point. It
history of
went to hematology
hemoptysis.
department and then came to you. Now the question is, what is the sequelae of diffuse and small little intrapulmonary hemorrhages that happens in idiopathic hemosiderosis? What happens to the lung?
It can cause lung fibrosis, and it can progressively goes to respiratory failure.
So how do you prevent that?
Sir, initially steroid is the mainstay of treatment. We'll start steroid, but if the child is not responding to that, there has been trial that we can go for other drugs, other immunomodulators like cyclophosphamide, cyclosporins, rituximab. They can be given.
Okay, over to Sharmaji and Rawat sir.
Sandeepan, what was the saturation of this child on presentation on room air?
So room air, it was 84, 85 like this. But with oxygen only, it was going to 90 to 95.
Okay, and your final diagnosis was idiopathic pulmonary hemorrhage complicated with pneumonia.
Yes, sir.
What do you mean by this statement?
Sir, the child was having underlying interstitial lung disease. That was idiopathic pulmonary hemosiderosis. But he didn't presented it because his body was being compensated by that. The only only presentation was 2 episodes of hemoptysis that we are telling. He told it was hematemesis and iron deficiency anemia, which was completely refractory to the treatment. So now when he has a pneumonia, then the things got complicated, and that's why he presented with interstitial pneumonia.
So what was the evidence of pneumonia in this child? You are telling that IPH and pneumonia are two separate entities. So what was the evidence of pneumonia in this child?
Sir, CT scan.
So that CT scan was sensitive of IPH. Why do you? So your entire finding was of IPH. No? So why do you want to use this term IPH complicated by pneumonia? What do you mean by this? Either you say that it is a case of IPH. Why do you want to separate these two things?
Pneumonia is a spectrum of IPH actually.
Okay, thank you.
One question only. What is the cause of fever in this child?
Sir, he was having pneumonia. That may be bacterial because his count was
the
high.
reason Dr. Rawat is asking you. It is not pneumonia. It is basically idiopathic pulmonary hemosiderosis. Whenever the iron is absorbed into the systemic circulation, fever can be there. It is not necessarily an infection.
Okay, sir. Thank you, sir. I didn't know that. Thank you, sir.
No more, sir? No more questions? I think then we'll go to the next case. Case code number 21, Abhijit.
Yes, sir.
Last case?
Yes, sir. Last case.
Abhijit, you share your slides.
Yes, sir, I'm sharing.
You have 10 minutes to go. It is 1:40 right now. By 1:50, you should complete, right?
Yes, sir.
Start.
Good afternoon all. Good afternoon all. I am going to present a case of a candida pneumonia in a child with severe acute malnutrition and rickets. A 3.5-year-old male child, third by birth order, born to non-consanguineous marriage, residing at Ganesh Colony, Pimpri, was to a casualty with a complaint of fever since 15 days, cough since 10 days, and difficulty in breathing since 2 days. On history, the child was apparently all right 15 days back when he developed a fever, which was insidious in onset, continuous, low grade, relieved partially on medication. After 5 days of onset of fever, child developed a cough, which was insidious in onset, gradually progressive, with no diurnal variation, productive, associated with post-rescue vomiting. Child developed difficulty in breathing since 2 days, which was gradually in onset, progressive type, and present even on rest. There is a history of not gaining weight and unable to stand or walk even at this age. In past history, no history of hospitalization for seminal complaint in past, no history of exophthalmos fever in past, no history of recurrent respiratory tract infection, no history of suggestive of congenital heart disease. There was no history of any COX or any COX contact in the past. In antenatal history, mother was ANC registered at the government hospital in second month of pregnancy, conceived spontaneously, received iron and folic acid tablets since second trimester, also received 2 TT injections in 5th and 6th month. Birth and postnatal history, the child was full term, was normally delivered. Now it was a normal vaginal delivery, cried immediately after birth. Birth weight was 2.3 kg. Breast weight was given within a half an hour after birth. There was no history of NICU stay. According to mother, 2 vaccines were given at the time of birth. In developmental history, the gross motor milestones were achieved up to the age of 9 months only. Currently, child can sit without support. Development question for this is 25%. Fine motor, language, and social milestones were normal as per his age. In dietary history, child was exclusively breastfed till 9 months of age. Complementary feeding was started since 9 months. Breastfeeding stopped at 15 months of age. Summarizing the diet history prior to the illness, the total calorie required were 1680 kilocalories, but the child is consuming 805 kilocalories. The deficit for calories 875 kilocalories. The total protein requirement for child is 19.6 grams per day, but child is consuming 12 grams per day, and protein deficient is 7 grams. In immunization history, child is completely immunized till date as per the national immunization schedule. There is a BCG mask present over left side. Family history, the child is younger to 2 siblings born to non-consanguineous couple. There is no history of any chronic illness, TB, heart disease, or respiratory disease in family. There is no history of any allergy or atopy in a family. In pedigree chart, we can see that only 2 years gap is between two successive pregnancies. The elder sibling is 7 years, middle one is 5 years, and the presenting company is 3 years. In socioeconomic history, according to modified Kupu-Swami scale, the family belongs to upper lower class. The summary to the history: a 3.5-year-old male child with history of fever, cough, breathlessness, with failure to gain weight, delayed gross motor milestones, with deficient protein calorie intake. The provisional diagnosis on history likely to be lower respiratory tract infection with undernutrition and motor development delay. On general examination, on admission, child was drowsy. Dyspnea was present. The pulse rate was 102 per minute. It taken in right radial artery, regular, good volume. All peripheral pulses were felt. No radiofemoral delay was there. The respiratory rate was 60 per minute. The type of respiration was abdominal thoracic with intercostal and subcostal retractions were present. The BP was 92/56 in right upper limb. The saturation was 68 on room air. Pallor was present with peripheral cyanosis. No clubbing, icterus lymphadenopathy was present. Anthropometric measurements, the weight of child was 7.5 kg, which falls below third percentile. The height was 72 centimeters, which is also below third percentile. Beta circumference was 10.5. Weight for length, J score was less than -3 standard deviation. So according to WHO classification, it falls in severe acute malnutrition. On head-to-toe examination, on head there was frontal and parietal bulging was present. Hairs were lusterless, scanty, and easily pluckable. Eyes were pallor, and oral cavity there is poor oral hygiene without any thrush. In chest, rachitic rosaries were present, Harrison sulcus present, and spectus carinatum. In spine there was scoliosis. In extremities there widening of wrist joint was seen. These are some pictures showing rachitic rosary here. The widening of wrist joint is seen, and we can see clearly Harrison sulcus here. In respiratory system examination, the examination of upper respiratory tract, in nose there was flaring of Allan-Azai. without any anatomical defect. No polyps were seen. In pharynx, there was no sign of any pharyngitis or tonsillitis. There was no any sign of air discharge or mastoid tenderness also. On examination of lower respiratory tract infection, on inspection, the child was tachypneic, dyspnea was present, RR was 60 per minute. It was abdominothoracic with intercostal retraction and subcostal retractions present. On examination of chest wall, the shape of chest was asymmetrical. The movement of chest wall was asymmetrical with decreased movement on left side of the chest without any scar or any sinuses, dilated vein or shining seen over there. On palpation, palpation was done in supine and sitting position. Tail sign was confirmed. The trachea was slightly deviated to the right side. It was which was normal for this age. Chest expansion was measured by placing both hands over the anterior, posterior, and apical region. There was decreased movement of hand in left side of the lung. No chest tenderness were elicited. Tactile Hooker parameters could not be elicited. On percussion, dull note is present in all the areas of left side of chest. Normal expected resonance on right side of the chest. Tympanic resonance were present in Traub's area. On auscultation, there were vesicular breath sounds present on right side of the chest. Air entry was reduced in all areas of the left side of the chest with crepitations. Vocal resonance could not be elicited. On a central nervous examination, child was drowsy at the time of admission, which was not oriented. Superficial and deep tendon reflexes were present and they were normal. No focal neurological deficit was present. In a cardiovascular system and abdominal examination, no significant findings were present. In abdominal examination, the abdominal distension was present due to hypotonic abdominal wall muscles. The final diagnosis for my case, according to the history and clinical examination, 3.5-year-old male child born of non-consanguineous marriage, third by birth order, with a history of fever, cough, difficulty in breathing, with examination findings suggestive of tachypnea and dyspnea, reduced left-sided chest entry, chest movement on respiration, dull note and percussion on the left side of chest, with reduced air entry on left side of the chest, anthropometric findings with weight for height less than -3 standard deviation, with mid-ass circumference of 10.5 centimeter, and presence of features suggestive of rickets, likely points to the diagnosis of left-sided pleural consolidation with severe acute malnutrition with rickets. We thought that at that time the Pune was at peak of COVID pandemic. So we thought the differential diagnosis of COVID pneumonia in view of pandemic and active cases in Pune. We thought the child was SAM. We thought it might be a bacterial pneumonia. Also the malnourished child, it might be a tuberculosis pneumonia or maybe a typical fungal pneumonia. These were the differential diagnosis. So on investigation and treatment, the course during hospital stay, as our hospital was a dedicated COVID hospital, the treatment was started based on the standard COVID protocol. The child was put on a nasal CPAP in view of respiratory distress and failure to maintain saturation. IV antibiotics like ceftriaxone and azithromycin were started, keeping in mind the differential diagnosis of bacterial pneumonia in setting of SAM.
Abhijit, you have 2 minutes left.
Yes, sir. Child did not improve in initial few days, and in view of increased work of breathing on nasal CPAP, child was electively intubated and mechanically ventilated to prevent respiratory failure. The blood culture were negative. Blood culture shows no growth. The work for TB was done, which was also negative. The serostatus was child was ruled out, but it was negative. RT-PCR for COVID was negative. As there was no improvement in general condition of child, gastric lavage was sent to look for any fungal growth, which showed a growth of Candida albicans, which was sensitive to fluconazole. Hence, the treatment with injectable fluconazole was started. We showed a dramatic response with clearing of opacity on serial X-rays. The child successfully extubated after a week of mechanical ventilation, and thereafter improved over the X-rays. Initial investigation, the CBC HB was 9 gram, TLC count was 12,500 with neutrophils 45, lymphocytes 40, eosinophil 4%, and monocyte in. Platelets counts were within normal. CRP was slightly raised with 23. Electrolytes were normal, but the vitamin D3 levels were 9.8 nanogram per ml, which was way below the normal range. Serum phosphorus was low, 1.3 milligram per dl. Alkaline phosphorus was raised, which was 14,005 international units per liter. ABG pictures showed respiratory acidosis. These are the radiological changes over the of the patient over the stay in the hospital. On day 1, when the X-ray was taken, it is clearly showed the complete opacities in pneumothorax. Then on day 7 of admission, after we have started antifungal, there's slightly improving opacities. And day 14, when the child was taken on nasal CPAP, the X-rays were fairly improved and with good air volume on both sides of the lungs. For the rickets, child was given vitamin D therapy. Workup was done and it was found to be a nutritional rickets. As we clearly see on X-ray 1, we can see a flare, cupping and flaring in the epiphysis of wrist bone. And after vitamin D therapy, we can clearly see a line of triangle, the healing sign for rickets. As the child improved and extubated successfully on nasal CPAP, child was started on F75 diet and slowly went off to the nasal CPAP. After 3 days, F100 diet was started. Child tolerated the diet well. There was appropriate weight gain of 10 grams per kg per day. Then child was discharged. Child was followed up after discharge. Child had appropriate weight gain. So the discussion was usually we think that in the SAM patient, more common pneumonia will be due to tuberculosis, but here it comes out to be a fungal. So we should think about the differential. Thank you.
On which day the sample of gastric aspirate for fungus was sent?
Sorry, sir.
On which day of admission the sample of gastric aspirate was sent for fungal?
Sir, on day 4, sir.
Day?
Day 4.
And when he was intubated?
Intubated on day 1, sir.
From where the fungus has come into gastric aspirate?
Actually, we thought the same. It might be a contaminated sample, sir. But after starting injectable fluconazole, the child's response was so.
The child may have a fungal pneumonia. I am not denying that. But I'm just saying, in an intubated child, is the gastric aspirate an appropriate sample for isolating fungus?
No, sir. Actually, it's not. But the
how will you interpret then?
The child was hemodynamically so unstable that on ET aspiration there was blood. So we thought it would be better to
attribute
take
that
gastric.
You already put an endotracheal tube. The ciliated movement could not
Yes,
bring fungus from lungs to the gastric aspirate after putting an endotracheal tube. So how the fungus will come into gastric aspirate?
It might be previous swallowing of sputum, maybe before the admission. That can be there.
So the fungus is surviving in the stomach for 4 days.
So, maybe.
Okay. Dr. Subramania, please.
My second question is, there is a definite malnutrition in this child, which I agree.
Yes, sir.
Do you think isolating the organisms always speak about cause and effect of pneumonia? And does it mean always or no? For example, I grow some culture, but do you think that is the organism always? Or can it be that the organisms are different and still we grow something? Maybe it's culture from stomach, from endotracheal tube, or from blood.
It might be different organisms, different. Due to malnutrition, there are many organisms. So they can be anything. We cannot stuck to the one particular thing.
Not maybe the real source of infection.
No, is there something hidden beyond malnutrition in this child? Is it possible?
There is findings where rickets.
Rickets was there.
Yes, sir.
What is the age of the child?
3.5 years, sir.
3.5 years. So any other cause you would think apart from the socioeconomic causes, anything organic which might have been missed possible? Unusual organisms. Was there repeated infections?
No, sir. Actually, there was no history of any repeated infection or no prior history of hospitalization. Actually, the family is so economically poor that they were like, we haven't shown to anyone.
So poor that their stomach can have candida, ma. I'm just telling you, they can
okay.
I'm just,
I mean,
this is in a
they
lighter
haven't
way,
followed.
of course. No, it doesn't matter. You have done a wonderful job. Rawat, sir?
Yes, Abhishek, you have presented a very good history and you have examined the case well.
Yes, sir.
2 questions. What is the role of galactomannan test in diagnosing fungal infection? Like, we didn't do this galactomannan assay. So could you have done that?
Galactomannan test.
Galactomannan. Would you have done that test to confirm whether it is fungal or not? Serum galactomannan assay.
No, no, so we haven't done it. Due to COVID pandemic, our hospital was completely COVID hospital. We were so restriction on investigations that we would if the COVID there were many restrictions in investigations, sir. It was a complete COVID hospital. It was, and so the investigations are so restricted in this case, sir.
Okay, thank you.
Thank you, sir.
Rawat sir and Sharma ji, I have sent my marks by WhatsApp to both of you. You can compute the total marks while I will give some instructions to the postgraduates. Are you all ready to know the marks total? All the postgraduates, please come on the screen now, please.
Yeah.
Sharma ji, you and Rawat can commute, complete the total, while I'll give them some instructions to the students as to how to present in competitions till then.
Rawat sir, I'm sending you my the number list.
Yes, sir. Okay.
I request all the students to enable their video and mute theirs.
See, basically, there are three students. Are you all ready? Just put that thumbs up now. You are all ready. You are awake, aware, not sleeping. Like usually it happens in seminars. Fine, no? Fair enough. And first of all, let me congratulate all of you. You are better than a whole lot of students who have not presented and who have not come up to the finale. So that's important. And all of you are winners. And I won't take some of you who could have some technical difficulties or could log in or couldn't answer. Doesn't matter. Nobody knows. Nobody knows.
Dr. Gaba sir, mute your.
Nobody knows everything. Nobody knows everything perfectly. And so therefore certain things can happen, isn't it? So don't worry about it. See, do you think that that would be the best of 10 minutes of you in the life? It's not possible. So that's the bottom line. See, it may not be, it may be your day or it may not be your day. So right, even in exams, it can happen. Correct? All of you agree on this point as students? You agree? You may be a very good student, but that 10 minutes may not be your best moments in the life. So that is bottom line. You may be a very bad student, but those 10 minutes could be a very good 10 minutes also. So don't always say, sir, he was not at all reading. He was not at all reading. Now he did well. So this also I see from students. So both versions are there. So don't worry about it. There are three things I would do. What I would do if I were to be a student. There are three things that you should do. One is plan. Second is prepare. And third is execute. Plan is 1/3, preparation is 1/3, and execution is 1/3. And execution is the day or the minute, correct? No, that's execution. You understand? But if you don't plan well, you will fumble in preparation and execution. Do you agree? So the first 1/3 is the most important. You should plan. And then how to plan for a presentation? It could be poster presentation in future. It could be that you will be a faculty and a speaker, or you could be a presenter, or you could be participating in a competition. How to plan? Plan, is an inverse pyramid. You have to read more and present less. On the contrary, you read less and present more is like hand, foot, and mouth disease, where you will invite questions for which you don't know the answer. You understood my point? When you speak a line, you should know 5 lines behind it. And this holds true for judges also. You can't ask a foolish question for which you don't know the answer. It applies to us as well. You understand? So it's not that only you are targeted, even I am targeting myself. So therefore, that's the difficulty that we have got. And so therefore, you have to plan well. What are the things I will plan? There are two types of plan, long-term plan and short-term plan. Long-term plan is reading and understanding, discussing, and understanding every concept. There are not one concept. And lastly, what message you want to give. And whether your message and your flow are in line. Let's say you should not, if you retrospectively look at your slides, There may not be flow at all from slide 1 to slide 4, some concept, from slide 4 to slide 10, some other concept, and last 2 slides are strange points that you would have come out, which is not linked to slide 1 to 2. Did you understand my point? The slide 1 should lead you to slide 2, slide 2 should lead you to 3, 4, 5, 6. You understand what I meant by the flow? And the last conclusion should not be de novo conclusions, it should be conclusion of what you have presented only. So how do I prepare the slides? I prepare from last to first slide. Unfortunately, all of you prepare from first to last slide. Do you all agree? All of you, now this point you tell me, this is a very good tip I am giving to you. You write down the last slide first. Then what happens is, you know what is to be written on the first slide. Mistakenly, you will give a big horoscope and a small conclusion. You will tell his nakshatra is this, Gotram is this, he was born on 1969, etc., etc. He was black at birth, and then finally tell that he did well. What's the point in telling so much? So whenever you are coming, what you want to tell should be first in your mind, and accordingly everything should fall back. Although in real life situation, you will not go retrograde. You will not say it will be pneumonia and therefore I'll ask questions on pneumonia. That is called leading questions. No, in real life, you will go prospectively, but when you are presenting, you should come retrospectively. And I will tell you, this happens even in your clinical bedside rounds also. First, you sometimes do a plantar examination, knee reflex, and then, come back to history and ask questions, isn't it? It does happen. So therefore, while you go prospectively, classically, but over time you will learn that you will come to quickly to and fro. You should be able to travel. Execution, few tips I will tell you. First thing is you must practice. How to practice? The best way to practice is keep the time and stand in front of mirror. And that will take you. And what are the best ways to present? Whether you know or not, you be confident. Most of us also don't know things. And you think that the judges means they know everything. Nothing, not necessary. It's easier to be a judge because you need not know anything. So basically what you should do is you must be confident, and the confidence should be visible. And what makes a good presenter? One is confidence, eye contact. Can anyone of the postgraduate be tell me which is the best of all the presentations done by the world leaders in elections, and a study has been done, and what makes the presentation the best? Can you tell me? I will show you poor and a good presentation both now for you. Can anybody tell me what makes soft skills that can make a good presentation till Rawat sir completes the commuting? Anyone can unmute. Is it the voice?
Connection with the audience.
Connecting the audience. How do you connect to the audience?
So by appealing to the audience, making eye contact with them.
Please connect to me. Anyone, please. This is important learning for you, and I'm teaching you the most important part in the life. How do you connect to the audience? Which part of your body connects well to the audience? Can you tell me?
Eyes, sir.
Facial expression, sir.
Eyes, sir. Eyes.
Yeah, eyes for your teenage problems, not for presentations. Narayan, do you agree? Eyes not for that. See, the most important point is you should have a smile on the face. That shows a lot of relaxation. One, the studies have shown that it's the hand. It's the hand. Many of us do not use the hands. Your hands should be free. Now I am showing you. What is the message I am giving to you? It's the hand. Now you see my presentation. It's the hand. It's the hand. And now I'll tell you the most important part is it is hand. The most important point is hand. Can you see the difference in the presentation? This is the key in diagnosis. This is the key in diagnosis. Can you see the difference? I know only this much. I don't know, sir. Can you see the difference? Use of hands. Have you used the hands? You have not used the hands. But sorry, this platform cannot make you to use the hands because it is very short window. So you have to go back a little and start using the hands. Sir, this was a 2.5-month-old child presented to us. When it presented, it had cough, it had fever, it had all the problems. But when we saw the case, this was the finding. Now tell me what kind of appeal you got. Was it appealing? Do you all agree? Agreed? 100%?
Yes, sir.
Shailam, do you also agree? Yes, isn't it? This is the key, and this has to be followed. Please start using the hands. And studies have shown this will give lot of inputs and value. I was observing is any one of you could use your hands. None of you use the hands. Doesn't matter. You are all tense. That's fine. The second part is the monotony of the voice should not be there. There has to be variation. 2.5-year-old child came with history of fever, sir. Then I got only 8 minutes, sir. Then there was lymphadenopathy, sir. Then there was height was in the third centile, sir. Did you understand?
Yes, sir.
So what is important and what is not important should be emphasized. So the growth parameters were okay. There was not much fever, but the child, was. Are you seeing the emotions with the expressions versus monotony? Are you able to see? So the variations in the language, and many of you shout, I don't know why. And tell me, is the voice with high intensity has more impact or low intensity has more impact? You reduce the volume when somebody is speaking loudly. And I'll show you both. 3-year-old child came with history of cough and bleeding from the nose, and then it had respiratory distress, and then it went to the nursing home, and they gave 2 injections and 3 tablets and came to us, and when it came to us, it had respiratory distress. Do you agree? This is shouting. And come to the lower voice. See, 3-year-old child was treated outside, had some issues, came to us, and when we saw there was a problem. Narayan, Harshini, Gopika, Swasti, was this useful tips from me? Even in exams. Even
Yes,
in
sir.
exams, you try to shout and try to bring all your adrenaline out while you go to actually catecholamine crisis. You will not be having any adrenaline when it required. And low voice does not mean swallowing the words. That is wrong. Sir, no, that's not correct. So every mannerisms of you will be observed. And in fact, in the first 4 lines only, examiners often decide whether you pass in an MD exam or fail. In 4 lines only, we can decide whether you know pediatrics or do not know pediatrics. And never give an opportunity of somebody to interrupt. Now I will tell you a presentation where if any one of you can ask me a question. 3.5-year-old child presented with history of cough, breathing difficulty, and fever of 2 weeks duration. To start with, the child had cold and cough. Then on the same day evening, the parents noticed that there was fever. The cough was dry, and however, the fever was to start with high grade. It was an abrupt onset. Mother could record the fever, and then they gave the paracetamol. Fever subsided, and for 4 to 5 hours there was no fever, and the child was playful and active, but again the fever came back. It showed an intermittent nature, while there was no chills or rigors as noticed by the parents. Did I give any opportunity for you to ask questions in between? Will you ask any question? Did you understand what I meant by presentation? You should not give a pass. I will tell you a bad presentation. 3-year-old child named Mansur Ahmad came from Muzirabad. Aadhaar card number is 355569. Father's phone number is 455555. Chief complaints are coming to the chief complaints. He had history of fever for 3 days. He has cough for 4 days. He has loss of weight for 2 months. Do you agree? Are you finding the difference between the two?
Yes, sir.
Right. And secondly, don't be very flat. What I meant by flat is, suppose you are a news reader for Times Now, and you are in Karachi, and just behind you are going to demonstrate a blast that has happened in a parking station. How will you present? See, I am from Times Now. Just behind me, this is a girls' high school parking where there is a blast happened at 10:15 a.m. and the blast lasted for 120 seconds. Will you tell like that? Or you will tell, right now I am in Karachi, the heart of Pakistan, You know, I am standing just inches away from the fire. Just a few yards behind me, there was a blast. In the mid afternoon, when many of you were having the lunch at a sharp 1:15, you know, I was into tremors when I heard the news. Did you understand the difference? Are you able to understand the difference between a flat presentation and even the emotions of the mother, problems of the child, the difficulties in investigation? Affordability should not be told. That should be obvious from your language. Can you all, you know, singing a song is different from Kishorda, Lata Mangeshkar to somebody when you sing. You know, there is no emotion. It is totally flat, bathroom sings. So you can have bathroom presentations also. You understood what I meant by bath. See, you are all now the creams whom I am addressing. That you can now go back to your colleges and see the presentations of students and how they present. It's very important. And secondly, you make use of the screen. And in drama and movies, we say you make use of the stage. Screen is the main thing. And it is said that in learning, more than 50% is visual impression. And if you are free, I will show you some of my presentations where Dr. Devendra Gaba and Sri Shailam would agree with me. Beautiful slides. And the slide speaks more than 80% of what I have to speak. So I am decompressed. Even you can depict emotions, problems of a child. There are wonderful Google images that are available, and sometime I will tell you how to present a PPT also. And lastly, I will tell you, you must attend to all your basics, like going to toilet, drinking water, putting some powder, taking all this choo things, all those things, talking. I mean, all these things should not trouble you in presentations. Unexpectedly, they can come. And when you want to handle user language, no, excuse me, you can start. Don't try to cough and then continue with your post nasal drip and your things. And then, you know, I mean, that could be the important line. You know, take a pause. Take a pause and take a pause where you want, where you invite questions. See, after a concept, for example, after a history, you could have summarized the history also. And if you summarize the history, you presented the history, then went for, and so therefore in our hospital, we investigated the child, the X-ray was done, correct? No. At the end of the history, I mean, whether you summarize the history and sometimes you should not read a slide. You can read from the last line and then go to the first line. Did you understand my point? So that's also important. So you break the audience auto reading. See, they should not go to trance. Basically, Swasti, you were referring to holding the audience. Never allow the audience to relax. That is called as holding the audience. You know, he should be surprised that you will be telling something which is not there in the slide. Then only his attention will not go. Rawat sir, when the moment you are ready, you tell me, I will close.
Sir, results are ready and Dr. Sharma would announce it.
Dr. Sharma would announce it. So was this discussion from me useful to all of you?
Yes,
Now
sir.
don't worry about the first second. I want some of you who have trailing, not getting the last but one, all of you should be able to make nice and wonderful presentations, and I'm showing you everything, each and every point that I have told you. And are you not realizing that all that I have told you is relevant, pause, important, and useful? You know, you understand what I lastly showed you the variations also.
Can I come, sir?
Sir, Sharma ji, sir.
Yes, sir.
You can announce, sir.
And everybody has done well. Now there is a big dilemma. We have got 3 candidates having equal marks at first level. So 3 people have scored equal marks, highest marks. So code number 14, code number 21, and code number 22, they have scored 52 marks, and they stand at first.
Can you introduce Rawat sir? Can they introduce themselves? Because code means I can't hear.
Could you repeat, sir? Could you repeat the codes?
Code number 14.
Okay, sir.
21 and code number 22.
Who are who are those three, please? Names.
22, we do not have any 22.
21.
21 is there.
Yeah, 20 and then 21 is there. Rawat sir has written 21. 20.
So 14, I repeat, sir, it's 14, 20 and 21. Am I right, sir?
20.
No, don't confuse.
Okay.
Rawat sir, you please send the marks to Sri Shailam. Let him announce with names.
Last one is 21. Last code was 21.
Yes, sir. 21 is there.
Yes, so I'm telling you, na. So please once again.
Sir, आराम से बोल दीजिए. If you want me to continue 2 more minutes, I'll continue.
Code number 14, code number 21, and code number 22. They've scored equal marks 52. Code number 14, code number 21, and code number 22.
Next announcement, sir.
And the next code number 35, he has scored 51 marks.
Okay, sir.
So you want only two, na?
Only two.
Sir.
Enough.
Only two.
No, the question is, can you tell Sharma ji, what are the numbers? Is there 22 with you?
I think it is 14, 21 and 41.
41. Okay.
Please see again. 1 second. Students, don't get confused. We are having some issue with 22. Don't get worried. Yeah, we'll solve it. We are solving in front of you. Sharma ji, just check with Rawat sir. He must have.
What you have sent is 14, 21 and 41.
Okay, fine. Done, sir. I'll tell out the names, sir. So Harshini has scored 51. Then we have the winners. That is 41 is Shruti Prajnakar. 21 number is Abhijit, whose number is 21. Am I right?
Okay.
Yes, sir.
Yeah, that's what, because there was confusion regarding. Then the 14 number, 14, code number 14 is Narayan Santuka. Narayan Santuka. So 14 number, Narayan Santuka 52.
No, can they introduce themselves for a while?
Yes. Yes, sir. All the four can introduce themselves.
And tell the case that you have. So we welcome Dr. Suresh Babu sir, who is the past president of respiratory chapter, and we will have some words from him at the end. We can have the versions from the winners. Can you speak, each one of you?
I first of all, I would like to ask. Hello. Yeah, Narayan Santuka, can you unmute yourself and you speak? Rest all will be muted. Narayan Santuka, 14 number. Yeah, go ahead.
Hello.
Yeah, go ahead.
Sorry, sir, my internet got disconnected, and so I was not able to be through for the last 1 minute. Thank you so much, sir. Am I audible now, sir? Hello.
Yeah, you are audible and you are the winner now. Can you speak something?
Thank you so much, sir. Thank you so much, sir. And sir, I would like to introduce myself, sir. This is Dr. Narayan, sir. I'm a second year postgraduate at Shishu Bhavan and SCB Medical College, Cuttack. And to be very honest, this is my first ever case presentation, and I was really nervous. And Subramania sir, you were so warm in the beginning that you made us so comfortable, and it was very important for me, to be very honest, sir. Coming to this case, sir, was admitted in December 2019, sir. initially we had the impression why we even admitted, because it was mild respiratory distress, but as it was a referral from a district headquarters, we admitted the case. And once it was not resolving, and when we went on ahead and ahead, we led to this like a rare discovery and all. So pneumonia, though a common diagnosis, every case of pneumonia has like potential to like surprise us with things like this, and we have had so many cases in the institution. Like the entire thing, being a first year postgraduate at that time, was feeling very beautiful, and getting this platform to speak and the support from the faculties, seniors was amazing, and I'd like to thank each one of you and each one of them as well, sir. Thank you so much.
Next, Dr. Abhijit.
Yes, sir. Thank you so much, sir, for giving us such a big platform to present a case. It was my first experience. I was a bit nervous when that technical issue came, but it was a good experience, sir. Really, thank you. I really want to thank my department, Dr. Ambike ma'am, Dr. Sandhya Haribakta ma'am, who were my guide. They guided me so well, and my co-GR. Thank you, sir. It was really a pleasure.
Subramanian sir, they require one more compliment because they were the first person whose case presentation reached us first. So it was motivation to all of yeah, sir.
Good.
Thank you.
That's
so
good.
The next is Shruti.
Good afternoon. It was a wonderful experience. I wish I heard Subramaniam sir's coaching session before I presented. It would have definitely enhanced the way I delivered my presentation. And like fellow participants, it was my first too. My name is a little difficult to spell and pronounce. It's Shruti Pragya. I am a 6th semester resident from Jipmer. Dr. Biswal, Niranjan Biswal and Dr. Venkatesh have been my guides and have thoroughly guided me even during the management of case and subsequently while presenting this case. And I would like to thank my seniors and colleagues too. Thank you so much. It was a wonderful experience.
Shruti, you are nodding the head more than before now.
It's just a digital platform, sir. It's very confusing when you don't know how others are perceiving the way you're presenting. So instead of my hand, it was my head nodding, I guess.
Okay, fine. No. See, I can see many of you, but actually, Kavita Chaudhary got tense in the beginning itself because he was the first to present, and we have some regards for the students who had to present first. It's fair enough. Shishalam, over to you.
Yeah. Next, I request Dr. Harshini. Unmute.
Yes. Good afternoon, sir, and I thank the entire IAP panel who was involved in conducting this event. And mainly, I would like to thank Sri Shailam sir for coordinating with us so well. And I would like to thank the 3 super cool judges, Subramania sir, Sharma sir, and Rawat sir, and also Subramania sir for teaching us the 3 mantra: plan, prepare, and execute. That will surely follow, sir, and will make better presentations. And I would like to thank my institute, that is Manipal Hospital, where our HOD Jagdish sir and Bhaskar sir for encouraging us and taking part in this events, and also my guide Dr. Archana, who's an ID consultant, for being so approachable and for guiding me well through this presentation. Thank you so much, sir.
Thank you, all the students. And Subramanian sir, I think we should have another webinar for grooming for a master speaker program.
No, if you feel that how to make PPTs and how to present, I can have one session for you. It's not very difficult. And do you all agree that some of the tips that I have told in those 2-3 minutes of time was something useful to you? But we can have many more things in the pipeline. But now we have seniors over here, and after that I will come to the other students. We have some. We'll invite some couple of comments from Dr. Devendra Gaba sir. Please clap him. See, being timer is most difficult because he has to be, he was not having any chance to go off. Sharma ji sir, correct?
Yeah.
Throughout the session. Gaba sir?
Yes. Sorry, I could not keep the time well. It was a little, we were a little delayed, but I tried my best. Yeah, and Dr. Subramania, I think you are excellent. You are out of the that way. I think you should be. I think we should have a standing oration and hats off to you, sir.
Thank you.
You
Thank
have
you.
done so well, nicely conducted. And my that ambassador of Pneumonia Week, she wants to just say hi to you.
Thank you. Hi. Okay.
Okay. Thank you, sir. Thank you.
Dr. Suresh Babu, sir.
Kindly unmute yourself, sir. Unmute.
Suresh Babu, sir. Okay, I think we have missed Dr. Suresh Babu. Once he's in, we'll see. One or two who couldn't make up and who had some nervousness. Dr. Kavita Chaudhary, you want to make any comments? Don't worry. We want you to now, next we'll conduct only session for the first one who was nervous to, win. we are not worried about Kavita, please. You are the first to present, no? Unmute. Unmute, ma'am.
Kavita, you have to unmute.
Unmute.
I think she cannot unmute. I have to enable her to unmute.
Yeah.
Yes, sir. Good afternoon, sir.
Now at least you don't be nervous, no?
Yes, sir.
Yeah. See, I think all of you agree that marks, 1 or 2 marks, either other doesn't take you anywhere. You have realized that you tell me in PG, you want a pass or you want marks? Then your answer will not be marks. If 51 is enough, isn't it? Out of 100. We all agree on this point. So if 52 may get a first prize, but 51 and 52 together pass, and 51 may earn more money than 52, so don't worry about it. So this we have seen. So this is only to tell you, this should be a healthy competition. You make a WhatsApp group of all of you, continue that group, post cases and learn. Lastly, Srishailam sir, I'm giving you the responsibility of compiling all the cases and making an album of pneumonia, which will be released from the respiratory chapter, all 42 cases, not only these 10.
Fine.
All of them.
Okay.
We will release
Done.
it as an album. See, and I would go one step ahead and with Sharmaji sir's blessings, we will make a module of interesting cases of pneumonia.
Good idea, sir.
We will make a module, and under leadership of Sharmaji sir only, I will not spare him, and again we'll give him some more work. Sir, this interesting cases of pneumonia can be presented somewhere in Jaipur, Respican, as learning points from pneumonia, and I would request all those 42 students to go to some garden or stand and present in the style you Shishalam. Over time you connect to them. I will really direct the movie in such a way that they can present beautifully, and that video can be played in such a way in a conference that everybody would love. There is no problem. One third is your knowledge, one third is your what you have acquired, one third is how do you present. It's most important. It's not a dress. It's about how do you present yourself, and you could see in the way I'm just talking to you also, isn't it? It's ultimately how do you present yourself, and that's the most important point that you need. And this presentability will also count for the patients. The mother will see the confidence in you, and she will listen to you. She will not force you. She will not pressurize you. She will come for follow-up. If you are like, see, sir, 3 loose motions, 5 times vomiting, did not sleep for the whole night, go. Then there is no interactions from you. Did you understand? So all these are important for you in life. These are small tips from us as teachers, and we will be there to teach you. Srishalam, you must take the charge of making the album,
Fine,
connecting to all of them. Get the PPTs from every one of them and a text.
Fine,
And
sir.
now we want a text combined with the PPT.
Fine.
PPT is a different style. It's bullet points. What do you mean by PowerPoint? Can anyone of you tell me? Harshini, unmute, no? What is PowerPoint? And what is Word? Word is text. PowerPoint means what?
PowerPoint, basically what we want to speak, we'll just put the keywords, sir. Later we'll speak out the complete thing.
See, this is the way you present. Shall I tell you what is PowerPoint?
Yes, sir.
PowerPoint should have the point and the point should have the power.
Yes, sir.
There should not be a point without power in a PowerPoint.
Yes, sir.
Now you have understood what is a PPT. Kavita, do you agree? Yes, isn't it? So it should have the bullets and each bullet should have the power. So PowerPoint means it should have power and it should be point. See, many of you would have realized that now you go back to your slides, there are many points without power and there are some powers without points. Isn't given undue importance. So if you balance the power and the point, it will become PowerPoint. And you should be powerful to present those points. That's all. This makes the presentation, and in 2 lines I have told you how to present cases in future congresses or conferences or whenever you are given the opportunity. So Srisailam, it is your responsibility. Only 15 days is given for you, because if you are given more time, the point is these students will forget the cases also. Within 15 days, the album should be ready and you should surrender it to Sharma sir for final editing. Sir Sharmaji, myself and you, we can plan something later on in Jaipur conference, because these are very rich material and real life cases. 42 cases of pneumonia, real life cases.
Good,
And
sir.
maybe something we will plan and moderate later on what the output. But we should be able to bring out something out of whatever that has happened. Now coming to the cash prize, last important, for which you are all waiting. See, if I divide 10,000 rupees amongst 3, each one will get 3,300 and the second prize will get 5,000. Should I do that? No.
No.
Shall we do one thing? No, if all of you agree, there was total of 10 plus 5, 15,000, isn't it? So how we shall divide, Sharmaji sir? Any inputs?
4,000 is to first and 3,000 to the second.
Sir?
4,000 is to the 3 first. 3,000 to the second one.
3,000 to the second. So fair enough. So Sarji is very good, and this should be okay for you, all of you. Yeah. And please become members of the chapter. And I think being the senior most person, first of all, we should thank Dr. Srisailam. You want to tell 1 or 2 lines, Srisailam, and before we close?
Yes, sir. I wanted to gather information regarding, is there any WhatsApp group or somebody of your postgraduates pan India? Because we were not able to communicate with every state coordinators, I think. So I think some of your students can take up this task, get a number, create a WhatsApp group of the postgraduates. Almost,
WhatsApp is not possible. Make a Telegram group, because WhatsApp has only 250.
Yes, I think Telegram group.
No,
that would be easy.
I would give the link of Telegram group of respiratory chapter itself. You join there.
And one more thing is that I'll be sharing the IAP respiratory logo, so that in your templates you can paste that in all the presentations. They can use the respiratory IAP respiratory chapter logo.
No, let them send it. We will edit. You can edit it. Don't share the logo with them.
Okay, fine.
They may misuse it. These students are very nasty. I'll tell you. They're cheaters also. That age is like that. They are in the various stages of milestones. Srisailam, I'm just joking. So don't worry. No, they may, for fun, somebody tag something. So logo is a serious matter.
Fine. Then I think it would be the better. We would do it so that we can edit. I think everybody
problem means I'm both administrator and an academician. You understand?
Okay.
I have the responsibility of safeguarding the chapter and its interest, copyright issues and all that will be there. So, but the thing is that we will give you the certificates to all of them.
Yes.
So please hold on to the group and make the group of all that 42 and let them all feel happy. So even their cases should be there. And all of you visit Respi Next in the Google. There you have all your cases will be presented. Further, one PG can take the lead. Harshini, you take the lead. One PG will take the lead. Rishishalam, that's how it happens.
Yes,
Harshini, you take
fine.
the lead. What you are going to do, because you are in Manipal and you are next to Jagdish Chinnappa, no? So it is easy for me, admin wise. I mean, others don't feel otherwise. See, the Next is uploaded from there. So it is easy for us to upload. What we will do is collect the cases of similar nature. All staff you put together and make a staphylococcal series.
Okay, sir.
Or I would say, you understand my point? Those which required intensive care series, severe pneumonia series, staph series, like that. Non-severe but unusual mimics series. There are mimics of pneumonia, correct? Majority of them. So you categorize them and make them clusters or series, and then take it forward. Harshini, did you understand the concept?
Yes, sir. Understood, sir.
Don't put on the serial number of your zip code or whatever code, that's 3142. No, that is not the order. The order should be with a concept. Make a concept based clusters and categorize them, and all of you can have a link with Harshini, and then Harshini will in turn give the inputs to Sri Shailam sir, and finally to Sharmaji sir, and then Sharmaji and myself along with Rawat sir will finally edit it. It should be fine. Fair enough.
Yes, yes, sir.
Shall we give it to Dr. Sharmaji being the senior most and my favorite teacher also for the final words, because the final words has to come from the senior most. Sharmaji sir.
Dr. Subramanian, for this honor and opportunity. We thoroughly enjoyed being with the younger generation. Everyone has done his best and we really enjoyed that. My good wishes to all of them, and we wish them to join the respiratory group and further pulmonology as their specialty in their career. All the best and thank you so much.
Thank you.
Okay. So, should we give the vote of thanks?
Yeah, you can give the vote of thanks, but all of you can collect the money from Harshini. We will reimburse her.
Okay.
Harshini, see, you have this Google Pay, BPay, PoPay, and all that. We don't have that. If you want, you send them, or we'll send a proper check from the respective chapter, something like that. It will be an honor that you can keep. We'll plan it out. Don't worry, that money will reach you, but the modus operandi and all, we will operate through her. It will be easy for us. Okay?
Yes, sir.
Yeah. Because, and I'll tell you honestly, I was not knowing that she's from Bangalore. Please don't tell me like that. Now only I came to know that she's from Bangalore. See, students, do you see an unbiased manner?
Yes,
Or
sir.
you felt that anytime we are biased? I was not knowing really who is who. Now I have identified, and therefore I'm giving some more responsibilities to her. That's all.
Can we take some feedback from any of the students?
Yeah, students, if you want to tell one or two words, you can. Please don't hesitate now, Naren.
If you feel that could be.
You look like being in FM radio.
No, sir, no, sir. I'm really enjoying what you were saying throughout the presentation, sir. Sir, I just again want to say thank you. I mean, you made us so warm and comfortable. That was so very important.
Yeah, Naren.
Yeah, it was Naren, sir. He spoke.
Yes, sir.
No, and who else is there? Naren.
Naren is someone else here.
Yeah.
It was really good.
Yeah, go ahead. Speak.
Thank you very much, sir. Actually, the session was so wonderful that I learned many things from our colleagues and different cases. It's a very good platform to discuss here, sir. It was overall very good, sir. Thank you. Thanks a lot.
Yeah. Anybody else? Please comment.
Always. Krishna Das.
Gopika Nair, her English was very good. I like the English of Harshini. No, let me tell you the positives. Don't worry about the marks. The presentation of Harshini, Gopika was good. And our, what is his name? Narayan. His language, his voice was also soothing. See, each one of us are having different voice, but I'm just telling you a few things. That's fine. Gopika, please.
Thank you, sir. More than the prizes or the cases that was discussed, I was so awestruck by the platform that was given to me, because I was in a part of world where I didn't know so many things happen in so many places, and the effective management, the thinking process, it is too much, sir. Like, it was a bombardment of information, and I'm so happy that I have attended this, and I shall raise my level and my academics to another platform from now on. I'm just
Gopika, are you also a singer?
yes, sir.
Then see, I can make out from the voice. You look at my way of approach. See, I'm judging even the finer things. Gopika, then sing a song for me. Let all relax now. They were all into staphylococcus, streptococcus, pneumococci. Gaba sir, do you agree? एक गाना
Yeah, yes, yeah, बिल्कुल
sing a
होना
song.
चाहिए.
एक
Gopika,
song you
yes,
like. Don't worry about all the
yes,
background and all. Just sing a
yeah.
song. It will
Yes,
actually make the atmosphere very nice. Sing, sing.
yes, sir. महागणपतिम् महागणपतिं मनसा स्मरामि, महागणपतिं मनसा स्मरामि, महागणपतिं मनसा स्मरामि, महागणपतिम् वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि, महागणपतिं मनसा स्मरामि, वसिष्ठवामदेवादिवन्दित.
Hello.
Will you sing for our inauguration of Respica National Conference?
Of course, sir. I'll be happy.
Okay, done. Gaba sir, remember.
Yeah, Gopika Nair.
Yes,
Gopika
sir.
Nair,
Yes.
see, you got more
You have to.
prize. Huh? See,
Yeah.
I don't know how I identified that you are a singer, because of voice I could make out that you must be a singer. Anybody else who wants to have one or two words or some kind of break? No, always into academics. You can just go off, and then finally we say bye bye.
Sir, I've written a COVID song, so can I?
Yeah, please go ahead.
This is in Kannada, so can I sing, sir?
Yeah, no problem. Anyway,
Sing.
COVID is not understood, so no problem.
ಎಲ್ಲಾರು ಎಚ್ಚರದಿಂದಿರಿ, ನಮ್ಮ ದೇಶದಲ್ಲಿ ಕೊರೋನಾ ತಡೆಯೋಣ. ಎಲ್ಲಾರು ಎಚ್ಚರದಿಂದಿರಿ, ನಮ್ಮ ದೇಶದಲ್ಲಿ ಕೊರೋನಾ ತಡೆಯೋಣ. ಹೊರಗೆ ಹೋಗೋದ್ರಲ್ಲಿ ಹಿತವೇನು, ಮನೇಲಿರೋದಕ್ಕೆ ನೋವೇನು. ಎಲ್ಲಾರು ಎಚ್ಚರದಿಂದಿರಿ, ನಮ್ಮ ದೇಶದಲ್ಲಿ ಕೊರೋನಾ ತಡೆಯೋಣ. ಕೆಮ್ಮಲ್ಲೂ ಹರಡುವುದು ಕೊರೋನಾ, ಸೀನಲ್ಲೂ ಹರಡುವುದು ಕೊರೋನಾ. ಆದ್ರಿಂದ ಎಲ್ಲರೂ ಮಾಸ್ಕ್ ಅನ್ನು ಉಪಯೋಗಿಸಿ, ಮತ್ತೆ ಮತ್ತೆ ಕೈಯ ತೊಳೆದು ಮನೆಯಲ್ಲಿದ್ದು ಸಹಕರಿಸಿ. That's all, sir.
Akashadipavu neenu. Correct, no? Yeah, nice song. It's a nice Kannada song. So
Nice.
you can understand, don't worry. I think it's the time to end. If there are no remarks from anyone, we will end the session today. But you would be the soldiers of our respiratory chapter for all the communications. So don't go away from the group. Whenever we send the messages, you send it to everybody else. So Gopika, you can contact us. If possible, we will try to make you sing in the beginning. So the students who have done, see, you represent all those who did not get money, okay? So you are given more opportunity. So that's how it is. See, I think those who got and those who did not get, all of you are at the end of the day happy, isn't it? So fine, fair enough. Okay, so bye. So we'll close the meeting and we'll log off.
Thank you, sir. Thank you, sir.
Thank you, everyone. Thank you.
Thank you, sir. Thank you.
ಅನಾಮಲಸ್ ಕನೆಕ್ಷನ್ಸ್ ಅದಕ್ಕೂ ಬಂತು ಪ್ರೈಸ್. ಚೆನ್ನಾಗಿ ಗಾಬಾ ಸರ್ ಬೈ ಬೈ. ದೇವೇಂದ್ರ